Am I audible? Yeah. Good morning, seniors and friends. Myself, Dr. Vinay Gupta from Kanpur, once again welcomes you all on behalf of UP Arthroplasty Society for 12th Kanpur Arthroplasty course. Yesterday, we had a wonderful knee session in which we learned a lot from our eminent national and international famed speakers. A very beautiful video demonstration by Dr. S. Prasad sir, my mentor, not only mine but hundreds of orthopedic surgeons over the country. Uh, how to correct varus knee by Dr. Maheshwari and valgus knee by Dr. Raja. Rule of cutting edge advanced technology by Dr. Greshan and many more. We had enormous case discussion presented by various presenters. Now, today we have our hip session, which definitely is going to be extremely fantastic, and we will try to cover each and every aspect of hip arthroplasty. In this session, we have our first session by Professor Dr. Rajesh Mehrotra from AIIMS New Delhi on direct anterior approach. Now I invite Dr. Saurabh Shukla from Lucknow to moderate the session and also invite our panelists, Dr. Harish Bhende from Mumbai, Dr. Anil Oman from Vellore, and Dr. Prasad Sir from Kanpur. Now I request Dr. Saurabh for further proceedings. Thank you. Over to Saurabh.
Good morning, everybody. Thank you, Vinay. Vinay is my batchmate. Professor Malhotra has been the person whom I have been closely associated since 1999 2003. He has been my mentor and teacher, and I strongly feel that Dr. Bhan and Dr. Malhotra have been the person who have shaped of what I am now right now. So thank you, Dr. Malhotra, sir. It's been a pleasure, and every time I meet you and learn from you. Dr. Prasad sir has been a very senior person who has guided me and many people around this region to do and learn new things. Dr. Nigam, Anil, Dr. Bhende, Dr. Jha, I welcome you all. I'm sure this will be a very interesting session because DAA is gradually picking up because Dr. Malhotra will, I'm sure will eliminate why. And also it's a new thing. And especially as Sir said that there would be many benefits, and obviously there will be risks and some side effects or limitations associated with it. And we as arthroplasty surgeons are always looking up to new skills, learning new skills, which will benefit the patients, not only the quality of life, but also the function. So rather than taking much more time, I would pass over the baton to Professor Malhotra to guide us, as he's the best person, I'm sure. One thing more I would like to enumerate, I don't know how to put, but I've worked with many surgeons around, but I think Sir Dr. Malhotra encompasses knowledge, skill, and technicalities all into a nutshell. So I think he's the best person to take this over. Thank you, sir. And please, I want to answer to you.
Thank you, Saurabh. Thank you for the kind words. Your students always have a biased opinion about you, and all of us have got students who will say those nice things about us. I'm going to talk about the direct anterior approach and show you a video demonstration. This will be on an ordinary table, and I'll keep on pausing to explain the procedures to you. So this is a 26-year-old male who presented to us with the avascular necrosis of the right hip. You can see he has an antalgic gait, and this is his X-ray. Now, point I want to make here is that although I know that most people do templating of the total hip before surgery, it is extremely important here, mainly because many of us with experience do what I would like to say intraoperative templating, which means as Dr. Anawat has guided, that measure the vertical offset, horizontal offset, and then recreate that during surgery, and even measure the size of the acetabulum according to the size of the head measured. Those opportunities are not available to you here in direct anterior approach, because the head has to be cut in situ every time, just like a severe protrusio. So it's very important that you template and have an idea about the sizes, although you will be using the fluoroscopy if you like. Now, I'll be demonstrating a short stem with a porous metal cup. Now, this is a patient who's positioned on an ordinary table, although this has an option to go down here. You can use a Mayo table here. The point which is being shown here is this is the beam from the X-ray, and this is the edge of the table. So anterior superior iliac spine should be at or just distal to the edge of the this part of the table, so that you can have a good imaging during the surgery, and that is always ensured before the surgery. This is the intraoperative picture taken of the same patient immediately after positioning, and you can see that you can see everything, and that is a great help intraoperatively. Although you can do direct anterior without any table, without any special instruments, without fluoroscopy. But I think, especially when you are beginning, it is a big advantage to have intraoperative fluoroscopy, because you'll suddenly realize that your component position has improved a lot. And eventually, when you go to indications like the bony ankylosis, you know, the orientation, the depth, and the size, they can all be correctly decided by intraoperative imaging when you are reaming or preparing the acetabulum. So so this is just, again, I'll take a minute. These are the specific instruments for this short stem. This is a right angle retractor, which actually usually we position at the posterior superior acetabulum between the bone and the capsule. This is a retractor which goes the medial neck. This is an anterior retractor, something like Cobra, which we put even in the posterior approach. This is a long-handled, low-profile retractor, which will go posterior to the posterior wall to keep the femur away when you are reaming. This is a instrument which is used. It's a double twin pointed retractor. This goes to the medial side of the femur when you are preparing, but we have often used a broad Hohmann for the same purpose. This is an instrument which goes behind the greater trochanter to help it to lift it up when you are going to prepare the acetabulum. This is an offset cup impactor. This is an offset reamer. This is a stem broach handle, and this is the rat tail. Now, having said that, don't get overawed by these instruments, because last year when we did CA, Dr. Cameron Cook from Australia, he was demonstrating. So he said, one day I told my team, we'll do this surgery with 3 normal Hohmanns. And I can tell you, it can be done. The inferior retractor, which you normally, those who have worked with me, I call it Rumal Wala Hohmann, that I put a sponge in the hole through the Hohmann and put it just outside the tal. That is done by a very special instrument by those who are, you know, chronic DA users, but we can put the same Hohmann and do it. So don't get overawed, but then it helps to have these. Once you are conversant with the technique, all these are not so important. More important is to understand how to use them. So this is the patient draped on the table. You can see the leg is draped free, and that has got several advantages. See, one of the reasons in fact, I have done it with the special table. You know, after I started doing, a year and a half late down the line, we purchased a new Mackey table, which allows us to do the direct anterior on that. To just get the feel of it, we did about 10 or 12 on that. But then I realized that I think I'm more comfortable doing it without the table, and I can argue the advantages of table, with table, without table. But I can tell you, without table is not a compromise. Without table has got several advantages. Now, the big advantage of table, the biggest one is, of course, to the one who's selling. But the other big advantage is that if you give me the table, you know, you won't see so many hands. I can do it with one assistant. So I think one of the reasons why table has become popular is where people are short of assistants. and they can afford the table, and the things remain controlled, and the those sorts of things which are more operational. I don't think that you do a less superior surgery if you use an ordinary table. So the first thing is to do the surface markings. The most key marking is the anterior sphenoid spine. Then you take a 0.2 centimeter distal and 2 centimeter lateral to the anterior sphenoid spine. You mark the fibular head, and from the point you have marked 2 centimeter distal and lateral to the ASIS. You can use this cautery lead, and then you mark an incision which can be 8 to 10 centimeters in length along this line, imaginary line which we have drawn from ASIS to the fibular head. So this is the incision being marked, and now we are ready to go ahead and incise. Now, so you can see the surface markings. Now this is the incision, and you will find some fat after the loose investing fascia. You can use a Kopp's retractor to remove that till you reach the fascia of the TFL. Now TFL, the key thing is that if you have gone along the surface marking, you cannot be in the wrong plane. But remember, TFL is always, the plane will be lateral to the ASIS. So you identify TFL by two things. One is the pink color, and second is the direction of the fiber. So the direction of the fibers will always be distal and lateral. So it will be moving like this. So at this point of time, you open the fascia of the TFL, and just like we've always done in all the surgeries which involve make a nick, take a Metzenbaum, and then divide this fascia. So this facial incision can be liberal. We do not be struggling throughout the surgery. So you actually do this, and once you have divided the fascia, then what you do is you take two Ellis forceps, and then you lift it up. When you lift it up, you need to erase the muscle from this attachment. And all of us were taught classically when you are taking the fibular graft that if you erase the muscles from the acute angle, it is removed easily. So I told you this moves in this direction. So I put in a Kopp from here and move it up. It just peels off the muscle from the fascia, and it leads you to the plane between the TFL and the rectus. So this is the separation being done, and then we are going to be in the plane between the TFL. You can see it's bloodless, absolutely bloodless. In fact, you don't cut anything. So it's a pleasure. The blood only comes from some place which I'm going to guide you and tell you and warn you. So now you got this plane here, right? This is the tensor fascia lata on this side. The rectus is on this side. So you have reached the posterior fascia of the rectus, and in this place you will find the branches of the circumflex femoral neurovascular bundle, and they are the ones which can be big trouble. If they are lot of people actually ligate them. I have seen even after ligation, if the ligature slip, they keep on bleeding like hell. Identify these neurovascular bundles. I prefer to coagulate them. You catch hold of them and coagulate them. There'll be one somewhat distal here. There'll be a couple of, sometimes if you are lucky, you will find the one going up here, which will actually prevent a lot of bleeding. To catch it and coagulate it. Once you have done that, you divide the posterior fascia and you are onto the hip joint, the front of the hip joint. Now, this is an attempt which is being made to orient you. I told you this is the right hip, this is ASIS, patient's head is on this side, foot is on this side. This side you are facing is the lateral side of the thigh. So now this is the medial homen around the femoral neck. You can just put a finger and you'll be able to put a retractor here. This is the right angle I mentioned. It has gone along the posterior superior acetabulum, and this is a Langenbach retractor. So this is how it is to orient you. This is superior neck. This is inferior neck. This is vastus lateralis. This is the hip joint. This is iliocapsularis. That's the lower or the deeper muscle, lying right on top of the capsule, and it is believed to give some contribution to the stability of the hip. And then this is the rectus on top of that, right? So, and this is the intertrochanteric ridge where the muscle is being, the capsule is attached. So once you have this orientation, we go ahead and remove the fat. Now, this fat removal is very important because this fat otherwise bleeds. Now, if you have nicely coagulated these vessels, you don't get much bleeding here. And some patients have hardly any fat, especially those who are thin built. But as a part of the surgical step, it is described that you should take this fat out. And now we want to remove this ileocapsularis away from the capsule. You know, it's adherent. So this capsule, this ileocapsularis has several, it has attachment and origin from the capsule also. And this is the fascia being divided. And then we use a corpse retractor again. Once we have separated, you know, you have to go deep to the ileocapsularis. That's why we identified it. And then lift it up with the corpse retractor. And then, you know, you got this, all this is the hip joint capsule. So that white shiny structure is hip joint capsule. So you use this corpse retractor, and then you are going to take anterior cobra retractor and put it there. So it is very important to remove these facial attachments. I'll show you again very soon. So it is important to separate out capsule as well as you can from the surrounding muscles. All the capsule, the muscular structures around the hip are adherent to the capsule, and you have to develop this plane so you see these facial adhesions between the muscle and the capsule. And just to tell you a little bit about the capsule here, you know, this is the capsule. So most important part anteriorly is the iliofemoral ligament, which is a condensation of the capsule. So it has got two parts. So one part comes here from the ilium, it comes here and becomes the superior capsule. And the other part comes here down there and becomes part of the medial and the inferior capsule. So this is actually a Y-shaped ligament of Biglow. You have the pubofemoral ligament coming from here, condensation, and coming and merging with the inferior limb of the Biglow ligament. And then we have the ischiofemoral attachment of the capsule, which is on the back side. So we try to separate out the gluteus minimus here from the capsule, the ileocapsularis here, part of iliopsoas here, so that all our retractors are sitting on the capsule and separating it from there. That's the intertrochanteric ridge, which is being pointed out, which is the attachment. So this is the anterior retractor. This is the superior capsule or anterior capsule. The anterior capsule, incidentally, is the most important restraint against the external rotation, which we will be needing to prepare the femur. So this releasing this anterior capsule is a very important part of the surgical procedure. So that's the capsule exposed for you right in front, and then you mark the capsular incision. We are going to make a relatively longer flap on top, which basically protects the gluteus minimus all through the surgery. And so this is the entry into the joint. You can see the synovial fluid coming out, make a vertical line. Then the horizontal limb can get along the intertrochanteric ridge, right? And you can actually extend this incision a little bit medially also to the top. You can call it, make it H shape if you like, whatever you want to call it. Start with a T, make it into an H. And then this is the capsular flap. Now we always secure this flap with a stitch because we want this capsule to remain there and protect the gluteus minimus, like I said. So that's the capsular flap. And so that is, we take a stitch, with an ethibond, and this is used to protect the gluteus minimus as it's taken on top. You have to remember that even the thread of these this stay suture can damage the tensor fascia muscle here. So the quality of your surgery is decided by what you are doing to the fascia. You take it away and put a retractor now between the capsule and the bone. Now this is the bone, this is the capsule. It is actually lying in front of the retractor is lying in front of the capsule, and which is protecting the minimus. Then you make an inferior flap, and similarly you will reposition this inferior retractor between the inferior capsular flap and the inferior neck. So that is again going to isolate the femoral neck for you, and it is going to protect the soft tissues around. You have the capsule exposed now. You have the, capsule divided and the head exposed. Good idea to move the head a few times because you are going to cut in situ and remove it with a corkscrew. Some people at this point of stage, and we have also done that a few times, will put a corkscrew extractor here. But whether you put that or not, you see the direction of your neck cut and you make two parallel cuts, one which is distally somewhat closer to your definitive cut, and the one is proximal because you want to remove a napkin ring. So always divide this proximal one cut first, because if you divide this one first, you'll have no control on the proximal fragment and it'll keep on moving. So while it is still attached to femur, make this proximal cut, then make a distal cut, and then you take a cockers, or sometimes we use just a towel clip if the thick napkin ring is too thin, and you take out this this napkin ring after making sure that there are no bony attachments anywhere. So you take this and then you take out the napkin ring. So you've got the napkin ring out now, because I told you won't be able to do that intraoperative templating. And so you will remove this, and then you are going to take the head out now. You take a corkscrew extractor and enter the head and move it a few times before you pull it out, because that will remove the adhesions and then the head comes out. So now you can have some idea about the size of the acetabulum. And at this point of time, not that we've got the head out, we need to do some releases for the purpose of preparing acetabulum as well as taking the femur away from the pelvis. So I just showed you by finger here. That's a part of superior capsule or a part of the iliofemoral ligament which needs to be released. So what is done is that you enter with a cautery here, and then you go between the labrum and the capsule, and then you divide this capsule here. So that will be roughly for the right hip, it will be around 1 o'clock. So this is the flap, this is the tensor, and you take this diathermy and then you divide this capsule. This is the superior capsular release, and that will help you expose the acetabulum better and also take away the femur. So you have, this is one release, right? So this is done, and then you concentrate on the, so you see you are actually getting exposure here. You can actually, if you like, divide the inferior capsule to the lesser trochanter right then. But if it is easy to retract everything, you can do it now. So we have this, this retractor here between the posterior superior acetabulum and the capsule. So this is the labrum. This is what we normally put at the inferior edge of the acetabulum. You can see I'm not using any special retractor here. I'm using a normal cobra here and a normal, what we call rumal wala human here, to put it inferiorly. And we got a reasonably good exposure to the acetabulum. Then we are going to put in a retractor here posteriorly to get the femur away so that we can prepare the acetabulum. So again, an attempt at orientation, you will be able to see some labrum here when you do that. And so this is actually, you have to orient yourself as it was being attempted. This is posterior, this is anterior, this is inferior, this is superior, right hip. So once you have done that, this is the acetabulum exposed, and it's very easy for you to actually ream the acetabulum now. So I always say that if you are an experienced hip surgeon, and I expose the acetabulum and femur to you and say you put the hip, you will do it without batting an eyelid because you know how to prepare. So there are no issues like malpositioning of component, undersizing, oversizing, or anything. The whole issue for an experienced surgeon is to get the exposure so good that he can just work like he does normally. So this is the offset reamer. Sometimes I have worked in a thin built patient with a normal reamer also, or a normal cup impactor also, but it is a help if you do that. The important thing to understand is that the reaming for this is different and you must orient yourself accordingly. The more the angle between thigh and your shaft, more is the opening of the angle. So if you want to make it vertical, you have to take the handle away from the leg. If you want to make it horizontal, you have to take it towards the leg. If you want to give anteversion, You have to lift the handle up, creating an angle between the table and the handle. The more you lift up your hand, the more will be the anteversion. The more you depress, less will be the anteversion. Extremely important step for you to understand that how you ream is very important so that you don't malposition the component. So you see, a lot of people, if they don't have good exposure, will recommend that you can actually remove the reamer, put it inside the cup, negotiate it, put it inside, and engage this handle inside. We don't ever have to do it because our releases are so good that the cup is exposed. But many times you'll see even experienced surgeon putting the reamer shell inside and then putting the handle to engage it inside, and then disengaging inside, taking out the handle, and then using a cocker to pull it out. Hardly ever need it if the releases are good. So this is actually a time for us when we are reaching the definitive size to check the image. So this is the image of the acetabular reamer. We know we are little undersized here, and we are not going to put this here. We are going to put the next size. But you can see the orientation. You can see the depth. You see that you have put it in the right position. You know the right size. That, I think, is one of the biggest advantage. I have been a posterior approach surgeon all my life, and this is a luxury you cannot afford, without messing up things there. So this is the offset handle now for the acetabulum. The important thing again is here is to put the holes in the posterior superior quadrant. So if you have to put the screws, they should be at the right place. So for right hip, they will be between 10 o'clock and 12 o'clock. For the left hip, they will be between the 12 o'clock and 2 o'clock. So make sure that your handle is put in such a way that the holes are posterior superior, and then you put some reamings as you always do, negotiate the cup inside, and then this handle will help you. So abduction angle is between the leg and the handle, and the anteversion you can see is not being kept too much because the real risk of dislocation in this approach is only anterior and not posterior. So we would like to do. So you just saw the position of the cup. You will be able to make out the anteversion by the ellipse which you see there and look quite good. And this is the time to put the screws. So it is being reamed. I must tell you that we put screws in 1 out of 25 in any kind of hip. But this fit was not as we would have liked. So we don't hesitate to put screws, particularly in this approach. In case you are struggling, then you don't want to pull the cup out. So this is the cup after the screws have been put. And if your cup is stable, there's no problem in putting in the real liner now. This is a ceramic liner. It's a young patient. And we are doing a short stem ceramic on ceramic. So that ceramic liner goes in and it's impacted, and we are done with the acetabulum. That's just a good assistant trying to prevent the spillage. So it's all done here. At this point of time, you can actually remove any impinging osteophytes if you like, because then you will start working on the femur. So the next step is you already have this flap. So we are going to excise this flap and in the bargain go right till the piriformis fossa. We are going to actually hold this flap. We have a stay suture there. We ask somebody to take a cocker. Another person takes a Langenbach and retracts the muscle away. Remember, I told you you have to work between the capsule and the muscular attachments, and that is how you end up releasing the capsule, excising it without damaging the muscle. So you go in the plane between the capsule and the muscle, in this case the gluteus minimus, and you excise this. So that is the second step of releasing the femur. The first one you saw was the superior capsular release. This is the second step towards releasing the mobilizing the femur. So this capsular flap is out. Now we make sure that the inferior capsule or the pubofemoral ligament is adequately released. So we excise this flap of capsule which we had left. At the same time, we must make sure that the capsular release goes right till the lesser trochanter. You should be able to feel the lesser trochanter. It's difficult to see it. Fortunately, in this case, you'll be able to see that you reach right till the end, and you'll be see lurking in the depth is the lesser trochanter. Yeah. So the inferior release again goes. So this release will again help you to externally rotate the femur and get it out. And so this is, you can see you have reached up to the, you can keep on gradually externally rotating until that time you reach the lesser, you see that lesser trochanter there, right there. The white thing is the lesser trochanter. So the point where I'm trying to make here is that you have to release inferiorly right till you reach the lesser trochanter. And now is the time for the final release. Right. So now we have to work in this area. That's the posterior. So I told you this is the posterior neck, this is the anterior neck. The posterior neck, the ischiofemoral capsule attaches. And that is actually a very big restraint. So we are not going to touch this part of the posterior capsule. We have to work between the 12 o'clock and 2 o'clock in this case here. And because it's the right hip. And we are going to remove the capsule here and also the conjoint tendon here. For that, it helps that you will need to externally rotate the femur. We have done the necessary releases to externally rotate the femur, but you will have to make sure that the greater trochanter does not is not lying behind the capsule, so that you when you externally rotate, it gets caught behind the acetabular cup and you fracture the femur. So you put a bone hook here and pull this towards you and up till the time you feel that this trochanteric flare is away from this. And then you externally rotate. That's where you will need either a table or the assistant or the whatever you want to do and reach this place. All that is being done to reach this place between 10 o'clock, 12 o'clock and 2 o'clock. Because once this is done, I can put a retractor behind this femur and lift it up, and it will all be delivered to me. It will be presented to me by extension, external rotation, and adduction of the extremity. So this is what is the orientation. This is the lesser trochanter, and you should know that this is the bone hook being put in. And see, because of the superior release and this, you are easily able to pull out the femur. When you pull it out and make sure that your trochanteric flare is not behind the cup, you will ask the assistant to externally rotate the leg. And once you externally rotate the leg, this 12 to 2 becomes completely exposed, and this is got the conjoint tendon. See, this is actually a textbook picture of how it is being exposed. And you release the conjoint tendon. The piriformis is somewhere here. It normally flips out when you deliver. If it doesn't, you should not hesitate to release that. Anything between this 12 and 2, which is stopping you, has to be released. But you can have a troublesome bleeder here. The bleeding or the hematoma which forms after surgery very often is from a bleeder here. And it is recommended that after you have done that 12 to 2, you should extend that release, at 2 o'clock diagonally up. Now, this is as it was. You slightly extend the extremity by taking the lower end of the table down, and this leg goes under that leg. So it's a figure of 4. You can see that. So now with this figure of 4, this leg is under the other leg. Release has been done. And if we put a retractor behind this greater trochanter, we'll be able to lift this this femur out. So this is again to orient you: posterior side, anterior side, medial, lateral, and then you use a rat tail. We call it a rat tail to open the canal. Always remember, just like the femur is bowed in this approach also. So when you are preparing femur from the posterior approach, you start somewhat posteriorly. You will find that your direction will most commonly be starting from the posterior superior end here and going somewhat there, and not exactly in the direction that it looks in the neck. So this is the bigger rat tail being used. And then you have the specific instruments for the stem. So this is the opener or the starter for the short stem here. And then this is the sizer. This is sizer. And then you start preparing. You can see that there's no special table. It's ordinary table. This leg is under the other leg. This is the smallest broach. It goes in. And, even with the posterior approach, some people have this fear of perforating the femur. So we do sort of check the integrity of the canal by passing in a thin bone lever. You'll see that being done just now. So this is just to probe the canal to make sure that we are not going out. Of course, we'll see the image also just now. There's the next size being going in. Looks like the definitive size. So the broach is in. So you again see that you have these special right and left femoral rest broaches, and you put the neck on this, and then you put the provisional head, and then retractors come out, and the hip is reduced. So once the hip is reduced, the first thing you do is to check the limb length. Then you see the image, and then you check the stability. So this is so convenient. This is the Shuck test being done to see the this thing, how lax the hip is. This is the extension and extreme external rotation, and you can see that this is still all inside, very stable anteriorly. It's now the outer side of the knee is touching the table, and it's stable. It's still inside. Flex, adduct. You can't do this on a table when the foot is tight, but then they'll say, you don't need it because there's no posterior instability. But then we get so many patients with spinopelvic deformity where we are playing with the cup position that we need to do it. Now we are happy with this, and we would usually take an image at this point of time. In this case, it has been taken after the real stem has been put in. So again, deliver it by the same maneuver. At this point of time, interestingly, the gluteus medius is horizontal. It's not on top. And this is the tensor. You put the real stem inside, impact it in. And then you are ready with the real head here. You can measure the offset at this point of time from the lesser trochanter to the trunnion, but you would have measured it preoperatively on the X-ray, and you can see how you have been able to reproduce it or not. A ceramic head goes in and is impacted in place, and the hip is reduced now. So all retractors come out. So all retractors come out, and this goes in, and then we are done here. And the closure is actually the best part. It is actually so simple that you really, if I move out of the theater at this point of time, the theater will be vacated within next 5 minutes, because the closure is actually so simple. Again, looking for impingement in all directions. Quite happy with this. And this is the image before the closure is started. And then this is the lateral view to see that it's not perforated anything. And then the closure is just closing this fascia. It can be a continuous layer. We don't use a drain in a hip replacement. And so this is actually pretty simple. From the time when you reduce it in, this is the only layer which needs closure. And this is how it looks after closure. And then this is the same patient 2 hours after the surgery, and all of them go home between 18 to 24 hours. And one of the reasons why I shifted to this was because we wanted to do daycare, although Kamaldeep does daycare, but with the posterior approach, but we feel this approach is more suited because there's no risk of patient going home and dislocating because of not observing precautions, or pain is much less because no muscles are cut. Now, I would like to take this opportunity to invite you later this month for Current Concepts in Arthroplasty 2021. We have it in All India Institute of Medical Sciences, physical meeting in the auditorium. And on 29th, we have a cadaver workshop on direct anterior approach. So that's a great opportunity to learn direct anterior approach on a cadaver. We have the eminent foreign faculty for the direct anterior approach cadaver course, as well as for the conference. We have close to 12 international faculty members, and one of them is possibly going to be here physically and do a surgery physically. And then we will have live surgeries as we always have in the current concepts in arthroplasty. I thank you very much for your attention and thanks for a very patient listening.
That was a great demonstration, Dr. Malhotra. Lovely. You make things look so simple. I think the proximal femoral releases should be something how to do, but you demonstrated it so well.
Sir, very nice. I think it's a very elegant and a very easy presentation of a very reasonable, unknown charter to many of us. I, for the sake, have been trying to get used to this. There has been a question from a delegate as to asking that how do we protect the artery? I think he's referring to the lateral circumflex artery. I guess so. Number one. And for the sake of the benefit of the delegates, I just wanted to ask that since we are working closer to the femoral triangle, do we need to worry about those structures while we are starting to do the direct anterior approach?
Not really. Actually, a point which I should have made, because when you are speaking live, some things are missed. So the cobra retractor which you put, it actually is classically said that it should be pointed towards the opposite kidney. So if you have that direction, and second thing is you saw that I released the iliocapsularis, then if you have, and then you release with the corpse, if you still have a difficulty in putting a cobra, you can slightly flex the hip, and then you'll be able to put your cobra retractor inside. And if you put it, anterior superiorly, aim it towards the opposite kidney, you are nowhere near the femoral triangle or the vessel or the circumflex vessels are not protected. They are ligated or coagulated, and you don't get any major. You are not supposed to get a neurovascular structure in this. If you hit it, you are gone way off. Either you've gone too medially, you've gone medial to rectus, or you have, and you would have seen that I divided the tensor fascia femoris muscle a little laterally, the fascia. If you do it too medially, then you may first encounter the plane between the sartorius and the tensor fascia lata. But if you do it somewhat laterally and then take the muscle off, you will land plumb between the tensor fascia lata and the rectus muscle, not to have to worry about the sartorius at all. So I don't think that if you do it properly, you have any business to see any neurovascular structure whatsoever in your way. You have seen I did not cut a single muscle, did not damage a single muscle. Patient has absolutely no pain post-operatively. There are no precautions. After being in arthroplasty for more than 3 decades, it's so pleasing to ask the patient, and not to ask the patient not to sit on a low chair or have this precaution. He can go. My first daycare surgery went home in an auto rickshaw the same evening after the surgery. So that's, and I told you that the fact that we can do it with a bikini incision in the large number of young females which we have here, except for the incision, everything remains the same. So, I mean, the newly married or soon to be married girls, they really value that cosmesis so much instead of having a big scar running or a small scar running over their gluteal area.
So there's a question from Dr. Badrinath Murthy as to this question is about the capsular closure. That's number one. I am sure that because there are concerns about the anterior dislocation in this approach, that's a valid question. And the second question he asked is that what is the status of and why you don't use a drain? Obviously, you don't use a drain. You have already asked. So these are the 2 questions which Dr. Badri has asked.
So first question is that 99.9% of the surgeons who are doing anterior approach do not preserve the capsule or repair the capsule. I know of a couple of surgeons who repair it. I suspect that those are the surgeons who would have got anterior dislocation at some point of time. But you have seen that stability. I just showed you with so much of external rotation and extension, the outer side of the knee touching the table. I don't think that because I can do it without excising the capsule. That's not an issue. But then it makes things more difficult, and with time you can get experience. But most people would say there is no need to repair the capsule. In fact, if you excise the capsule, I'll tell you, in our circumstances, we are not, I showed you avascular necrosis of the hip. The Westerns are doing it on primary osteoarthritis of the hip, not on arthritic hips, not on Angstpon's, not on tuberculosis. So the capsule is so scarred and so thick that if you are able to repair it, it will actually make the hip very tight and not let the patient extend if the repair holds. So I don't think that's a great idea, and nor is it required. Right. And the second question was about drain. Now, we stopped using drain because the lot of literature suggests it doesn't help. Unlike knee, where I still use it, where a hematoma can really make you lose sleep if the knee is distended. It's a deep-seated joint. And third, the hematoma will form, but it will just take care of itself. It will not present to the surface, and it will a closed space. But third and most important is that all the drains, to my mind, to somehow compromise early mobilization and definitely compromise early discharge from the hospital. We are not keeping patients for 24 hours. So how long do we want to keep the drain?
Dr. Malhotra, I have a question.
Yeah.
You had made a T-shaped, wonderful demonstration, a T-shaped incision on the capsule, and you retracted the capsule with the stitch.
Yeah.
And only after the acetabulum implantation did you excise the capsule.
Yeah.
What is the benefit of doing that rather than excising it off earlier on? Because your acetabular exposure would have been, this is just a question. So, and because you kept it till the end of the acetabular exposure to excise both the bits.
Yeah. So
would it have helped to excise it earlier so that you can expose the acetabulum better?
I don't think so, because
But what is the benefit of keeping it till?
I'll answer both your questions. I made a flap and I put the retractors first before the neck resection, neck cut. Right. That time the muscles were being protected from the saw blade by the capsule. So that's number one. So that was, and I did make that point that I was keeping this flap to protect the soft tissues, because there will be a layer of capsule between the saw blade and the surrounding muscles. Now, before exposing the acetabulum, I did release the superior capsule. That is all that is required. This part has been released. And again, at all points of time, with the grating surfaces of the reamers going in and out, the capsule provides you some amount of protection against this. But when you have to prepare femur, this has to come off, because that's the culmination of your final.
Yes, it has to. It has to. Yes.
Sir,
I think the key to it is the release. I think.
Absolutely.
Sir, I have two questions. Number one is that the classical advocation is basically a straight linear incision in the DAA. Now, I know that Chris Cotton has modified into, and so you have been doing into a bikini approach. Now, does the change of the incision from a longitudinal to transverse make the procedure easier or difficult? What is your perception about it?
It doesn't make it easier. It makes a little more demanding. That's why we waited till we did our first 40 hips before we went on to the bikini incision. But it's actually, once you get used to it and you got the retractors at the right places and the correct releases, I think to me, it doesn't matter anymore. I won't think twice about the last bikini incision hip I did was day before yesterday, which was the last OT day I had. It doesn't, so you should not have an incision which starts showing you at the ends, like Dr. Ranawat says, that you make a small incision and then try to stretch it too far. But in females, generally the tissues are more lax. So that's why we have never felt the need to do this kind of bikini incision in men. Although I have been questioned and confronted as to why men don't need a bikini incision. But I think that can wait. But then the tissues are also a little lax in females. And I think that's an advantage. We have selectively done it only in females, except for the first one, where we were, sort of testing the waters. We did it in a male. We didn't want to do anything to a female which might disfigure. So you can feel my obsession with female vanity. And I think there's no reason why the Indian females are not entitled to their own vanity and cosmesis compared to the Western one. Although I don't know how many Western surgeons have ventured into this.
From Malhotra, when you are releasing the superior capsule, do you protect the reflected head of rectus femoris, or it is released in the same way?
Nothing is released. It is actually a little away from the reflected head. So I told you for the right hip it was 1 o'clock. So actually the classical teaching is that you go between the labrum and the acetabulum and you cut from inside out. So I use the diathermy to divide the capsule from its deeper aspect, from the articular aspect of the acetabulum, and there's no way you can come across the reflected head from there. You just divide the capsule. You don't release any muscle at all in a classical direct anterior, and you don't need to.
I have a second question. There has been, apart from releasing the anterior capsule, some people have advocated releasing the superior aspect of the capsule as well, because that saves the short external rotators. But that's just what they say. In your experience, does cutting independently the short external rotators made any impact in your surgery, or have you felt anything like that?
So I'll tell you what. I showed you a release of the conjoint tendon. We don't release the piriformis, and it's not recommended, but it is said that, so I said that shortly, that once you release the conjoint tendon and the capsule, once you rotate and deliver, the piriformis flips over the trochanter and goes behind. If it does not, it may prevent its coming out. And in that case, the classical teaching by Jose Rodriguez and the group is that you can release the piriformis also. But to tell you very frankly, I have been able to get away without releasing the conjoint tendon and just releasing the capsule in short stem, because my exposure required is very limited. But we do a large number of Ayushman Bharat patients, and they classically, if nothing else, what is available for them is a corail. And the corail is something which needs, extra neck cut if you want to sort of restore the native offset. So your cut will go close to the lesser trochanter or even to the top of the lesser trochanter. So in those cases where I'm doing a long stem like that, there is no way to do it safely and adequately and efficiently without releasing the conjoint tendon. I have not seen any problem with the posterior dislocation by releasing the conjoint tendon, nor has anybody else. And in fact, if you see what Hospital for Special Surgery group is saying, they say, because they don't do short stem, it's a standard recommendation that you have to release the conjoint tendon and you have to see the whitish tendon being cut and getting retracted and going away. And you should be able to feel the hollow fossa of the trochanter, just bare bone. That's how it should be.
If you are doing long stem, are you releasing few fibers of gluteus medius for the reaping, or it's not needed at all?
No, we don't touch anything. What happens is, I told you, the gluteus medius fibers in this position become horizontal. Horizontal, almost like you saw the direction of the neck before I cut it. So, and this is, no way they come into the way. No muscle is released, no muscle is touched in a normal, straightforward direct anterior approach.
Sir, have you encountered any problems of not using the table and getting the femur hyperextended? I mean, has any?
See, you have seen figure of 4, right? Figure of 4 may be a little difficult for corail. So we have a very sort of flexible approach. So what we normally do is, see, I told you the advantages of the table, right? Patient is fixed. Wherever you keep the limb, it stays there, right? It's not that your assistant is moving or the position is changing. And there's somebody unscrubbed who can keep on rotating. And the first time I saw it being done on the table, I was horrified because it was looking like what is called as bhoot ka pair, because the toes were pointing towards the floor. That much was the external rotation required. So I'll tell you a simpler way to do it, the way we do it. We put the leg on a normal table. We take out the leg part of the side to be operated. We put it on a Mayo's table. But we keep a Mayo table whose height can be adjusted. So you can actually, when you want to prepare the femur, you press the foot pedal, the Mayo table goes down, the hip gets extended along with that, and then you adduct it and rotate it. It will automatically, you will have to push the Mayo table underneath the other leg towards the opposite side, towards the unoperated side. So make some room for there. After that, either it can be held there or an assistant can sit on the stool and hold the leg there so that it doesn't go all over. And then you can prepare it. So you don't really need a special table at all.
Okay. Any other questions from anybody? Sir,
Just one question, Dr. Malhotra. What is the risk of getting an injury to the lateral cutaneous nerve of thigh? Because you are somewhere quite on the top of it when you are doing this surgery.
Yeah. So it has been reported in some series up to 80% and other series up to 20-25%. And in fact, my assistant, the second inguinal, the bikini incision I wanted to do was a young girl who needed bilateral. So she wanted it by direct anterior. So my assistant went and told her that bikini incision has a slightly higher incidence of injury to the lateral cutaneous nerve of the thigh. So next morning she said, I'm not getting it done by bikini. You do it by the standard direct anterior approach. But I am yet to see a troublesome meralgia peristatica. The risk is very high, but we, like everybody else, don't look for the nerve and we don't see it. And if I saw that it has been injured, I won't do anything about it, because the literature which describes up to 80% incidence also describes that near 100% recovery with gabapentinoids and
Sir, last two questions, which concerns me. If I have to start an approach, number one, literature notes some amount of femoral perforation while using while in the starting of the learning curve. That's number one question from my side. And the second question is that about the anterior instability, which obviously the literature says. Your views about these while starting to do these procedures to begin with.
So to answer your second question first, the anterior instability, we all know that in an anterior approach, you tend to put cup in more anteversion. This was described when I was a resident, when direct anterior approach was not even in vogue. And it was, the Smith-Peterson approach. So avoid putting the cup in too much of anteversion. You consciously push the handle down. So that is the way to control the anteversion. And second thing is the imaging which you take. I told you, if the ellipse looks too wide of the cup, then you know that you have put it in too much of anteversion if you have not paid attention to the handle. So if you don't put it, and if it is in the table, it is stable, I don't think you have to worry about the anterior instability at all. And your first question was?
The first question was that about the femoral perforation or the fracture, periproximal.
So because it was a longish answer, I kept it for later. I said there are two ways to learn the direct anterior approach. First is when you are learning hip replacement. So it is for a person who's inexperienced, if he learns the direct anterior approach when he learns the hip replacement, he will have a very low complication rate. The second is that a very experienced surgeon. So a very experienced surgeon, I mentioned that a very experienced surgeon, if the femur is exposed to him and the acetabulum is exposed to him, he will not malposition or cause a protrusio or cause a perforation. So the risk of perforation is there with the posterior approach also. So if you are not conversant with your total hip instrumentation, and if you have not done releases, the perforation, the fracture of the femur, all are possible. So those are the real complications and you should not ignore them. So that is why I said, if you want to learn it, if you're a very experienced surgeon, your learning curve will be less. If you are a new surgeon, you will learn it possibly with least complication. Switching over is when it is a little difficult. That's why I understand from a posterior approach to anterior approach, how people can get confused between version. That's why I paid special emphasis on how do you keep the cup, make the cup open, how you make it closed, and how you adjust the anteversion, so that it is different from putting a cup by the posterior approach.
I think.
Can I have the last question?
Yes, sir.
Right.
Yes.
Last word, sir.
No, thank you. I just wanted to know if soft tissues are very tight, have you ever extended your incision towards the iliac vein?
Not really, sir. In fact, my fourth or fifth case was son of a minister who had septic arthritis of the hip, which was drained anteriorly 20 years back. And I told him that I am not so experienced, but I feel confident that I'll be able to do it in you because I want to excise all the scarred infection which had occurred because of previous infection and the surgery. So, sir, the muscles hardly ever get scarred. It's the capsule. So if you excise the capsule, nicely and do your releases, it has never, even a bony ankylosis has not been a problem. So it's the muscles don't get that scarred as to prevent surgery. It's the capsule. And my logic to him, and he understood that. I said, I'll take possibly 2 hours to do what I can do in half an hour for you. But it will be for your benefit because I'll be able to take out all the scar tissue from anterior. Imagine trying to remove the scarred anterior capsule all the way from a posterior approach. So the soft tissues are not a problem. Capsule is always the problem, and that is excised very well from this approach.
And lastly, how do you make your removal of the head easy? What is the trick?
So I told one trick, sir. That was that many people do that. Maybe I think next video demonstration, I'll make it a point to do that. So when the head is intact, you can see some cartilage because of the anteversion. You can see part of the head. You can hammer in a corkscrew extractor into the head before dividing the neck. That's one thing. Second thing is taking out the napkin ring is a way to make room for the femoral head so that it can be taken out. The third is you rock and roll and rotate the femoral head before trying to pull it out. Because other than the ligamentum teres, all other adhesions should be freed, which is not so difficult. And in the end, it's only the ligamentum teres which remains. So if required, you can actually pass in a scissor and cut it. So making room for the head by taking out the napkin ring, putting a corkscrew extractor in the best part before dividing the head and rotating it well and taking it out and still in a very osteoporotic bone, the corkscrew may cut through. So I've had to do everything, including reaming in situ, like we do for a protrusio, which can never be in a protrusio and fibrous ankylosis, which the head can never be taken out. We generally gradually ream it out. We have done that also. Even that may have to be done. But these are the tricks to do it in a good quality bone.
Dr. Malhotra, can you just dislocate and then do the osteotomy? Is it possible in anterior approach?
It is not possible, nor is it recommended. So because you see the amount of external rotation required with all the pubofemoral ligaments and all, you will have to do very excessive releases to release it, because those restraints to external rotation are the anterior capsule and pubofemoral ligament. You will have to do very extreme releases, and if they are adequate, you can fracture the femur. So nobody in the world recommends. If you just are lucky, some people I have seen just while doing, they're just lucky to, it just pops out, it's fine. But if you do your preoperative templating on X-rays, I don't think you have to worry about dislocating it, because that has got more harm than benefit.
Sir, there have been, when we start an approach to begin with, the first approach obviously we recommend is that we do something in a hip, in a fracture neck of femur. Now, do you recommend doing this a DAA?
I've always said that, and I should have told you when you asked what is a good case personally. A fracture neck femur is a good case, and one of my first few cases was a direct anterior approach for a fracture neck of femur with a dual mobility cementless shell. And now that you have said that, the first direct anterior approach in India was done during current conception arthroplasty. I think it was more than 16 years back. We have Hari Bezwada, who's a Zimmer surgeon, come in from USA, and I had to pay for his ticket and his instruments, a big tray of retractors he brought. And then the second was an evolutus surgeon. So once it was a young male, about 55, who had a road traffic accident and had bilateral fracture neck of femur. And in CC, and we would have the recording of that surgery. One side was done a Zimmer hip by direct anterior approach by Hari Bezwada. That was the left side. And the right side was done by a French surgeon who did a evolutus stem and a evolutus dual mobility cup. So yes, it's a good way to start, particularly because the risk of dislocation is higher in fracture neck of femur. The tissues are lax, so much of releases are not required. Maybe you don't release, may not need to release the conjoint tendon also. So yes, that's a good point to start.
And I think that covers everything. Dr. Nigam, sir, boss, anything else? There is any other questions we have for Malhotra, sir?
I think we should move for a second session.
I think that's fair enough. We can move on and next session, which is again very, very interesting, which will be talking about again concepts of total hip replacement from luminaries of joint replacements. So we can go to the next session, I think.
Yes, Vishal.
Dr. Vishal is there. So Dr. Vishal Agrawal will take us further from here. And thank you, Saurabh. You did also a very good job of getting the right answers from Professor Malhotra.
No, thank you, sir.
Yes, credit goes to you for all the right answers. Because you are the one who got them out.
Thank you, sir.
So I thank Dr. Rajesh Malhotra for such a lucid talk and a very nice demonstration of each and every aspect related to the anterior approach, table-less, of course. Now, I would like to invite the eminent orthopedic surgeon, Dr. Anand Nigam, who is also the additional joint course director, for the next session as moderator. And Dr. K.D. Tripathi from Prayagraj as a panelist, with Dr. S.S. Jha from Patna, who is our patron also, Dr. Harish Makkar from Lucknow, Dr. Vinay Gupta from Kanpur, and Dr. Pawan Gupta from Kanpur as panelist. Handing over the process to Dr. Anand Nigam.
One comment, Dr. Pawan Gupta is among the group, the youngest, and again, we are blessed to have him in Kanpur, because now Kanpur can boast of a lot many good joint replacement surgeons, and Dr. Pawan Gupta is again one of them.
Thank you. Hi, everybody. Now we are starting with another interesting hip session. Our first speaker is Dr. B.D. Chatterjee from Kolkata. I know him since long, from the very first conference of Ranawat in Goa. We were together. Way back. I think, and the most important thing is that he's going to be born tomorrow. I think, and happy birthday to you.
In advance.
Thank you. That's wonderful thing to have you with us. Now, his topic is why exposure matters in total hip arthroplasty and when to choose what. In our student days, we were taught that you do the hip arthroplasty the way you are comfortable with, the approach you are comfortable with. But later on, as we become a little bit more experienced, we realize that this is not the case. There are many ways to go to heaven. So I think that thing now makes a lot of difference, that which exposure you choose, which precautions you tell the patients, and how to do it comfortably in other approaches. I think a versatile surgeon is a surgeon who knows to approach a hip in many ways, not in one way. I think this lecture has a lot of importance. Dr. B.D. Chatterjee, sir.
So thank you very much. It's really wonderful to be again amongst all of you, and thank you for the kind introduction. My sincere thanks to Dr. Prashad for the kind invitation. It's a real privilege and honor to be speaking here. So let me share my screen. Am I audible, by the way?
Yeah, very well.
I don't know, somehow, okay, all right. Can you see my screen? Hello?
Yes, sir, we can see. Yeah, I can see your screen.
Is my screen visible?
Yeah, of course.
Yes, okay. Okay. Thank you. I think we were privileged by an extremely illuminating lecture by Professor Malhotra. And so there may be a little bit of repetition, but so does really the surgical approach, how important it is? Of course, it's important because you need to really see what you're doing. And they say that the success of a total hip replacement really is half of it is on your exposure and how well you can actually visualize, 360 degrees of the acetabulum and a good view of the femoral neck. So does the approach matter? The point is well taken that yes, I think that what you said regarding what you're comfortable with, I think that still applies to some extent. And there are two ways of looking at it. One is that you become an expert in one particular approach, because I would say more than 95% of any hip surgery can really be done through whatever approach that you are familiar with or you've been trained in. The other approach is that you get expertise in everything and then pick and choose depending on the patient. But the defining features, which approach you will choose for which particular patient, is not very clearly defined. So anything can be done by the posterior approach and anything can be done by the anterior approach or the lateral approach for that matter. So let us just go through briefly what are the various approaches. Now, this is, there is a preoccupation with different surgical approaches, and it is a somewhat touchy subject because each one thinks that his particular approach is the best. So to stay away from the controversy, the things that you look at recovery time, you look at hospital stay, incision length, wound cosmesis, and then that versus the complication rate, the implant survivorship, does it have a role, and the functional outcome. Now, the AAHK survey 2010 found that the posterior approach is by far the most popular. Now, 10 years on, this may have changed, but this is what the scenario was in 2010. The ideal hip exposure, you will obviously like to do minimal hip dissection, so the anterior approach scores there, preferably intramuscular. You should have a clear orientation of the acetabulum and the femoral neck version. So possibly the Hardynger approach is beneficial there. It should be extensile. The posterior approach scores very, very handsomely in that aspect, and it should be stable after closure. And of course, if the pain recovery is rapid, then as Professor Malhotra is able to discharge his patient on the same day, then that's again something desirable. So position, does it matter? Supine position. Advantages are that you are more certain of the pelvic position. You can see the acetabulum a lot clearly, and you can you can be very sure of the leg lengths that you have achieved. Disadvantage is that only anterior approaches are possible, and fat and sometimes bulky muscles in male patients can get in the way. In the lateral position, the advantage is that both approaches are possible. The fat falls away, so you don't really have to worry too much about retraction. But then the problem is you have to be very exact or precise about your pelvic tilt and the position which you can lose during retraction and manipulation. So if we look at very briefly the posterior, lateral, anterolateral, and anterior approaches, this is a diagram which shows you how you enter you can see the green arrows show you the anterior, lateral, and the posterior approaches. This is the posterior approach incision. This is the relevant anatomy. Obviously, the sciatic nerve is something you're worried about, and you have to take precautions against that. This is how you incise the fascia above the gluteus maximus. And once you retract the gluteus maximus, then this is what you see. I think the piriformis tendon is a landmark here. And you could, in the posterior approach, it is preferable that you detach it and retract it in order to get a better exposure. There's some controversy about release of the gluteus max insertion. There's a paper which says that you can get a sciatic nerve palsy if you don't do it. So I think a lot of people do it, and some people don't. So this is where you retract the soft, the short external rotators, and then when you open the capsule, you have a very good view of the hip joint. So just a demonstration here, a few pictures I can show you. This is what you see. You can see the tendon very clearly. And then when you take it out as a flap, I prefer to take the capsule, posterior capsule, as well as the short external rotators out as a flap, and then you can see you can expose the joint very well. The closure is important. I think numerous papers have shown that you must really do a good closure after a posterior approach. And my preferred method is to take anchoring sutures through the trochanteric crest and then tie them together, and gives a very, very secure and solid exposure. Advantages, it's quick and easy, relatively bloodless, it's fully extensile, so you can do a lot of secondary procedures. If you have to do an ETO, etc., this is a good approach to do it in. You can see the anatomy very well. It spares the hip abductors. Post-operatively, the patient does not really have a Trendelenburg lurch at all. And it is the preferred approach worldwide in most revisions. So obviously, this is an approach of a lot of significance. So the precautions: strict lateral positioning, the pelvis must really be secure with clamps. You can release the gluteus max if you wish. Care while placing the hormones beyond the anterior lip of the acetabulum, because there you are fairly close. You're about an inch away from the artery. Impingement by the acetabular remur by the femur is something you must take care to get the femur well out of the way. Otherwise, you can ream in retroversion. And there is you have to recognize the tendency that you always tend to retrovert the socket. So you have to take care and really get the retroversion correct. Now, if you compare anterolateral versus and transtrochanteric versus posterior, this is a study by Picard and Coleman fairly long ago, and there they found this is the comparative analysis, and there is the blood loss is more or less the same. There's a slight limb length inequality which is noted, but we know that by modern techniques, especially those put forward by Dr. Ranawat, that we can really avoid all that. Hypertrophic ossification is a problem with the anterolateral approach. In the posterior approach, 75 to 90% dislocations were reported in 1992, but a meta-analysis in 2002 shows that it is really much less than that. And all the recent studies have shown that the dislocation rate is less than 1% if you do a good, secure, definitive posterior capsular repair. So this has really been a game changer, and it has taken the fear away from the posterior approach. Dislocation rate, if you see, no difference in 5 years, and the more recent study, even compared with the direct anterior, one study from Japan, no difference in dislocation rate. So I think a lot of things have changed in recent years for the posterior approach. Now, if you look at the anterolateral approach, the advantage is, it's a fairly common approach. So most of surgeons are trained in this. Good exposure to the acetabulum, easy to judge the acetabular position, very low dislocation rate. But there is a problem of potential abductor weakness because of retraction and because of partial release of the gluteus medius. That patients do have a Trendelenburg gait as shown in literature, and it's not a very extensile approach. So anterolateral approach, I think we'll skip this. This is just a few pictures to show. This is the incision, and this is what you know, and then this is how you release. This is just to show, go through the surgery quickly, and you dislocate by external rotation. You can hang the leg down from the table anteriorly, and then you can use the brooch to do the femur. Anterolateral versus posterior comparison, this paper by Phelan. Here it says that there is a change in Oxford hip score between 3 to 12 months, but there is really no difference at 5 years when you compare these two approaches. Direct anterior, I'll just go through this very quickly. I think we've already seen a wonderful demonstration, so I think we'll just skip this. And so obviously it uses the intermuscular plane and internervous plane, the soft tissue preservation, supine position. You can use fluoroscopy much more easily in this, and that gives you a very good idea of your implant placement. Posterior capsule is intact, which ensures a low dislocation rate, and the hip abductors are preserved as well, so there is no Trendelenburg gait. However, there is a learning curve, according to most people. The special equipment which was necessary now, I think a lot of people are doing it without this. A very interesting point raised by Harish that there is a lateral femoral cutaneous nerve injury, although maybe it's not a matter of such concern. It cannot be done really in complicated cases. You have to select your patients really very, very carefully for this. So that could be reported as a disadvantage. So in a young female of light build, maybe it's a good approach to use. And there has been higher complication rates reported. This is a paper by Hozak, by Polvisi and Hozak. 6 significant orthopedic complications in the first 72 cases. So like I said, this is a somewhat touchy subject. So there are arguments both ways. Just a word about minimally invasive minimal incision THA. This used to be a big thing a few years ago, but today I think most of us have moved away from it. Using a small incision can be supported if the technique does not result in a higher early complication rate, nor does it negatively affect the long-term performance. But if you see the paper, then really no real improvement in early post-op outcomes and at 6 weeks. So really there is so a lot of questions being raised. So there was no difference between mini and standard posterior approach, and the increased rate of wound complications in the minimally invasive approach. So again, some comparisons between minimally invasive and standard posterior, better early function outcome, but no difference at 1 year, no difference at 6 weeks, no difference at 1 year. So I think because of all these studies, here again, a comparative study by Howell and De Beer, and so really there was not much difference between the two, the standard and the mini incisions, which is otherwise more difficult to perform. So that's why it has perhaps fallen away. It's not so much in vogue today. The factors that substantially influence speed and ease of recovery incision of any length really is the following. This is from a paper by Vail, patient education, patient preconditioning, accelerated rehabilitation, and very importantly, I think, multimodal pain management. So these are the areas where we must focus and not so much on the incision size. Again, some interesting paper by Parvizi and Rothman from the Philadelphia group. So factors that influence the outcome was education, conditioning, analgesia, improved pain control, rehab, and the size of incision really didn't matter so much. So in summary, I still think the type of approach and the length of incision may contribute to an accelerated early recovery, but long-term results are generally the same. So perhaps again, therefore, it's not that important. The ultimate assessment of implant longevity and survivorship, that is what determines the success of a THA. Familiarity of anatomy plays an important role, and therefore I think it is much easier, and perhaps results are better if you stick to what you're familiar with. Most of the cases you can do with this, except the very few that you really need to change your approach. And any potential short-term gain should not be jeopardized the long-term outcome of THA. So approach is important, yes, but I think every approach has its advantages and disadvantages. You really must know the disadvantages so that you can work around them, and you can achieve excellent results with possibly with any approach. It's only very limited situations. One I can think of is an ankylosing spondylitis with the limb fixed in severe external rotation. That's where it is difficult to do a posterior approach. So you might want to switch to an anterior approach, or you can do a tent approach where you can do the neck osteotomy anteriorly and then go back posteriorly. So that apart, I think if one is well trained in one particular approach, should be able to do most of the cases. I thank you for a patient hearing and bring you greetings from my city of Kolkata. Thank you all.
Thank you, VD, for a nice, lucid talk. I think you have opened the horizons by which the hip can be approached for other indications. We have got a lot of questions. In the last, we are going to ask. Now, our second speaker will be Dr. Harish Binde. I think I have yet to see a sincere person like him. I have with him in 2003, Bombay Orthoplastic was, and you taught me a lot at that time. Now, today he is going to deliver a talk how the tips and tricks for getting a non-cemented THR. Non-cemented THR sometimes become very easy, but your 3D view in your brain makes a lot of difference. And that's where the role and the lecture of Dr. Harish Binde lies. Dr. Harish Binde, sir.
Thank you, Dr. Anand, and thanks for inviting me for this conference. Without wasting the time, I will start with the lecture. Basically, when you talk about non-cemented, it is better than cemented because there is a direct bone implant bonding, and it may presumably last longer. So we normally like to use it in a younger people. We like to use it when the bone quality is good, or especially in a revision situation or in a MI surgery, as you have seen, just an excellent demonstration by Dr. Malhotra. Basically, when you want to do it, we have to realize that it is a technically more demanding a surgery because there is no cement as a filler to bury the mistakes of a surgeon. So that's why your rimming, your implanting has to be absolutely accurate. And that is why there are many questions which come to the surgeon's mind when they are trying to do the surgery. Number one, we must get a good exposure. There is no question about that. Whichever exposure technique you use, either anterior or posterior or direct anterior, it is very essential that if you want to do non-cemented acetabulum, you must be able to see the all corners of the acetabulum, the anterior wall, the posterior wall, the superior wall, and the ligamentum teres quite well when you are actually going to implant the non-cemented cup. Also, you must be able to see the proper femur by adequate rotation. Now, when we are actually reaming and doing the acetabular preparation, some questions come to our mind. Number one is, what should be the direction of a reaming? Now, it is very important that to realize that there could be commonest thing is you ream centrally first and then ream in 45-degree upward direction. That's many times people advise to do. And many times people keep on reaming, rotating the reamer while reaming. It's very important to realize that both of the things should not be done because both of them can cause problem. You ream centrally only when there is a medial osteophyte, and if the osteophyte has shifted the femoral head out. So in those situations, you may have to ream centrally first and remove the osteophyte so that you can know which is the base of your real acetabulum, and then start reaming in a 45-degree inclination the way you want to put your cup inside. Then how do you know that when you started reaming, that the reaming is enough? Now, if you look at the acetabulum like this is a horseshoe-shaped inverted position. You have a posterior wall, posterior column, anterior wall, anterior column. When you start reaming, you start seeing the pinpoint bleeding around the acetabulum. And when you can see the pinpoint bleeding in the anterior wall and a posterior wall, that means you have finished the reaming. The acetabular anteroposterior dimension is very important because that is a true acetabular dimension. Many times we template the acetabulum based on the pre-op X-ray, and the templating is done by a vertical dimension. And this vertical dimension is usually slightly more than the anteroposterior dimension. So when you start reaming, and you can see the pinpoint bleeding in the anterior wall and a posterior wall like this, your AP dimension is reached, and that should be the size of your acetabulum. You should not be reaming beyond this by maximum more than 2 millimeter. Then, should you remove osteophyte before you actually do the reaming in the acetabulum? Now, many times people want to remove osteophyte to look at the true acetabulum. What I have realized that in many times in Indian patient, especially female patient, the acetabulum is slightly shallower, and in which case, keeping the acetabular osteophyte usually give additional depth. So if you ream with the acetabular osteophyte in, and you can get a proper fit, your acetabular fit can be better because you get a better fit at the periphery. After putting the trial and actual cup, if you find that the acetabular osteophyte are too long or too protruding, then you can at the second stage remove the osteophytes so that they don't impinge with the neck or a trochanter of the femur. So normally we should not remove the osteophyte unless they are so big, like in the case of protrusio hip, that they interfere with putting the reamer inside the acetabulum. So don't remove the osteophyte before actually implanting the cup because they can give additional depth to the shallow acetabulum, which is not uncommon in a female patients. Now, when you start reaming and you put a trial cup and you get a situation where the cup fit is not very good, the cup is slightly loose, what should you do? Should you ream with a larger reamer and put a larger cup, or should you go deeper? Now, ideally, if your cup is not fitting very well after you are reamed adequately and you have apparently reamed as much as you have planned it, and then the cup is not fitting very well, you should not go for a larger reamer. First thing you have to look for is your anterior and posterior wall. If your anterior and posterior walls are not very thin, then you can go for a bigger cup and you can go for a deeper cup if you have got a medial wall. So two things I do normally. I look at the anterior wall and the posterior wall to see how much thickness is there. If the thickness is more than a couple of millimeters, then I can go to the bigger cup. And second thing is, I need to see whether medial wall is adequate. So simple thing is, you can put a small 2 millimeter drill bit, make a medial hole, use a depth gauge, the standard depth gauge which you can use. So you know how much medial gap is there. And if there is adequate bone, if your cup fit is not good, go by to the smaller cup size, smaller rimmer size, go a little deeper. And because of the added depth, you may get a better fit of a cup. So it is very essential not to blindly go for a bigger rimmer or a bigger cup, because you end up sometime doing more damage. So if this is a acetabulum, this is just a demonstration what happens if you try to do over rimming. You are rimmed adequately to that level. We have reached the edge of your posterior anterior wall, and suppose the cup is little loose and you want to do bigger rimming. So you start using bigger rimmer and you rim to that size. So basically what happens, you increase the size of rimmer beyond the size of a cup. You are going to remove a lot of bone from the periphery, and this actually causes acetabulum which is wider but shallower. And that shallower acetabulum can make it more difficult for a bigger cup to fit, because now that cup is going to remain more proud and more unstable by almost that much distance. Now, suppose you are done little extra rimming and you realize that even the bigger cup is not very good. It is not fitting very well. So what should I do? Many times people advise that, okay, put that last rimming into the acetabulum and then try to fit your cup, because then that last rimming from the acetabulum will add to the bone. Should you do this? Put a last bone graft in the acetabulum so that your cup is fitting better. Now, actually, if you try to do it, it causes things more, it causes more worsening of the condition. Look at what happens when you do this. This is an acetabulum which you are over rim, and the peripheral bone is lost. And now you want to put this rimming in the bottom. Now, what you have done is the already shallow cup has become shallower, because your acetabulum rimming will not go to the periphery where you want the fit. It will eventually settle into the bottom of the rimmed acetabulum. So it becomes more shallow. So putting the rimming into the cup and trying to fit your cup inside, in fact, cause more problem, more damage. So you cannot do that. So if that actually happens, you put a acetabulum which is oversized, over rimmed, and now your cup is not fitting very well, what should you do? The only thing which you have in that situation is use multiple screws to fix the acetabulum. Maybe you can go for a cup like a Gription cup, or those which have got a special coating, which has got a better scratch fit. Or last option could be you can switch back to a cemented cup and cement the acetabulum with a cemented cup. So these are the bailout option when you have accidentally over-rimmed the cup while doing the non-cemented acetabular THR. Now, many times people ask me, should you do under-rimming and put a one size larger cup? And that is the commonest thing many people say, and make a common judgment that, okay, I under-rim by 1 millimeter or I under-rim by 2 millimeter and put a bigger cup. Now, this is an extremely dangerous statement to make, because many times you have to go by the system recommendation, because the biggest misunderstood fact about non-cemented cup dimension is some companies give you cup dimension inclusive of the surrounding lining or surrounding coating, and that makes it much bigger. For example, if you use a cup with a DePuy system, the cup lining is just about 0.25 millimeter beyond that. On the contrary to that, a Zimmer cup has got a much bigger cup. So many times when I used to use a metal on metal arthroplasty long ago, now it is abandoned, the ASR cup, if you have to rim and put inside properly, I had to actually under rim by 1 millimeter. So put ASR 50, I had to rim 49. But if you do the same thing to the Zimmer cup, which was called Durham, I had to actually over rim, because the Durham cup, the dimension was excluding the size of the coating, which was almost 0.75 millimeter on that cup, so which was collectively 1.5 millimeter more. So Durham 50 was actually 51.2, because of which I had to over rim when you have to put Durham cup. So we have to realize that when you say a blank statement that I under rim and put a larger cup, you have to see which company you are using, because each company have some guidelines and recommendation. And after doing certain number of cases with that cup, you come to know that what should be the best way of doing it. Second factor about under rimming or over rimming is you have to realize the quality of bone. Many times you do a patient, which are young, avian patients, sclerotic bone, and in this situation, you try to under him and put a bigger cup, there is a good chance that you may fracture, create a peripheral acetabular fracture. So it is very important that you do not under him too much and put a bigger cup in a young patient with a good quality bone. A patient is elderly, say about 55, 60, 65-year-old, bone quality is not very good. You can afford to do underhemming and put a bigger cup and it can still accept and have a good fit. So these blind recommendation of underhemming or overhemming should not be done as a general rules. Go by the system recommendation. And the bottom line is, do not try to change the systems many times. Don't do one system for the 5 operations, then go to the next system for the next 5 operations, because you don't get a feel of the system. So in a non-cemented THR, it is extremely important that a surgeon should not keep on switching between different companies. Use one company for 30, 40, 50 patients, get a feel of it. And if you are unhappy about certain things, then try to explore with the other company. So this is extremely important thing to prevent any intraoperative fractures or complication. Then you come to templating, and especially in a case of femoral size, templating is very important because we must be able to match the center of your replaced hip to the center of the femoral head which the patient has. And for that, we must have a proper X-ray which has got properly magnified and matched with the magnification of the template which you are going to use. Now that is altogether another lecture, how to template for a non-cemented hip. But when you template in a proper way and put a template on the X-ray film like this, you have to see that the black dot is the center of the femoral head and the hollow dots on the template are the centers of the prosthetic head. So looking at that, you now know that if you use a central dot or a central head or a neutral head, you will be keeping the length equal, but you will be going to reduce the offset by maybe 2 or 3 millimeters. If you go for the longest head, you may get offset right, but you'll be elongating the head by almost about 2-3 millimeters. So templating gives you a rough idea about if your implant is placed the way the template is put into the bone, then where will be your offset neck length geometry. So upsizing will give you a longer neck length and a longer offset. Downsizing will give you shorter neck length and a shorter offset. And that jugglery can be done on table by surgeon after you have put the trial component inside. Now, usually we have to realize that when you talk about implanting a non-cemented stem into a femur, depending on the quality of a bone, if the bone is softer, you may gradually upsize easier. So you may have template for say size 10 cup, 10 stem. If you use really hard broaching, you can even go a size up because the softer bone can impact with the broach and you can get a bigger size. But if you are talking about younger patient who has got a very good quality bone, and you can see the corticomedullary index there, the cortices are very thick and a central cavity is little narrower, that means the bones are going to be hard, then you may not be able to upsize. You have to go either the same size or you may end up having even a downsize because the bone may be harder than what you feel. So you have to realize that sizing or templating is only for a rough guide. During the surgery, actually what happens depends on the quality of your bone and whether you want to do upsizing or a downsizing. Now, this ability changes how you think during the surgery. For example, how does it help me? How does it affect my technique? Now, when I'm broaching for the femoral stem, I start broaching gently. I should not hammer it. It should be tapped inside. And I stop at the first time. When I put the broach inside, I actually try to rotate the broach in and out and see whether the broach rotates inside my cavity or whether the broach makes the leg rotate. This is a posterior approach which is used by most of the people, and you are looking at the femur from the surgeon's perspective. The broach is inside the femur, you can see there, and you are holding the handle of a broach and trying to rotate the broach inside the femur. Now, at that point, if the broach stop rotating internally and it start moving the femur, so the legs start rotating side to side, then you know that you have reached the first good fit. So that I call as a soft fit or a first fit of a stem. Usually, in most of the patient, you can go for one size up because that much amount of impaction can happen with a bigger broach. In non-cemented stem, you do not get more than two options there. So I stop at the first best fit, which is the first soft setting of a stem. Then I do my trial and see whether my offset neckline options is good. If I feel my offset is small, I have option of going to the bigger second fit, and they can automatically I get a bigger offset. So you can use this ability to put two options of femoral stem. The first option, that is the soft setting or the first setting, or the second setting. Now, this is the way it is done. Now, in younger patients, usually I end up putting maybe a little smaller than the actual templated. Now, it is very important to realize that we do not have to fill the entire cavity of the femur. In a younger patient with a good quality of metaphyseal bone in the femur, you may use a smaller implant than actually what is templated if the fit is very good, if the rotation of the broach doesn't allow the internal rotation, and it actually you can rotate the leg with that, because the benefit is that you can always, it becomes easier to remove the implant. On X-ray, that implant may look smaller, it may not fit or touching the medullary cavity walls, that is the cortices, but it can still be very fit and very stable. In the older patient, that option is not there. Usually you end up broaching when the broach touches the peripheral cortex, and you may not have a bigger size of option available. Now, once you put the implant, you must measure the offset neckline during the surgery, and then you have to find out whether my offset and neckline is matching the pre-op measurement which you have done. And then you do the reduction, and then you do certain checks. What I check normally is I check for the soft tissue balancing. So I rotate the hip, see whether I can get full rotation, internal and external. If my hip is balanced very well, I can do orientation of the head with respect to the cup. So we do parallelity of the head and the cup. So that is a combined anteversion, what is described by Dr. Ranawat. Then you look at the soft tissue impingement and at what range the hip is completely stable. If there is an impingement between the soft tissue or the bone, that is the time when you have to remove some of the osteophyte around the acetabulum. So these checks has to be done once you are done the trial reduction, because at this time you still have option of doing slight amount of upsizing or changing the offset, or you can even go for a high offset or a low offset implant, because many companies now give you high, low or intermediate offset implant on the femoral side. So you must use all those options while doing this trial reduction and trial check. Once you have done the trial reduction, you are happy about it, then you can go with the implanting of the actual implant. Now, if I'm not very happy, I still have a possibility of going a size up on a stem. I can still use a longer or a shorter neckline, and you can do additional soft tissue releases. So basically, at the end of this, we must get a stable hip joint. For implanting, as it has been very well demonstrated in the surgery today, the entry point should be quite lateral and posterior. That's the posterior part, lateral part, and that's how your entry should look. And you can see that the calcar is quite medial. So when you broach, when you start broaching, you are broaching from the center of the femoral cavity. So usually you are in a aligned very well, and there is very low risk of keeping the implant in a varus position. So the checking of version again is done with respect to the leg in a posterior approach. In an anterior approach is done in a different way. This is a posterior approach where you look at the vertical axis of the leg and you keep your implant looking downward by about 15 to 20 degrees, depending on how much anteversion you want to check. So basically, non-cemented THR is not so easy, because we have to be very accurate about how much we rim. We have to be accurate that our implant cemented cup, non-cemented cup is sitting very well. It should not be very loose. It should not be very tight. Risk of fracture should not be there. And the stem size should be well sized, so it is fitting very well with recreation of offset and neckline. There is no cement to bury the mistake of a surgeon. So that is why many people think that non-cemented THR may be more difficult than a cemented one. But in fact, if you understand the basic principle of how to rim, how to put the cup, how to size the stem, how to measure offset neckline, and what to check after doing a trial reduction, non-cemented THR is actually much more simpler than a cemented THR. Thank you very much.
I thank you, Dr. Harish Bhinde, for a nice talk. I think you have said what I want to say, that uncemented hip is definitely a better or easier choice because you have got a lot of time to do whatever you want. But you have to have a very good concept and anything that you can do an uncemented THR with a due precision. I thank you for a nice lucid talk, Dr. Vinay. Now, I invite Dr. Anil Arora for the tips and tricks for cemented hip. Cemented hip, I think, is a hip which always keeps on giving tachycardia to all the orthopedic surgeons, because it is a time when you have got a very little time to improvise yourself, to make you accurate and to do a precision work, because after that it becomes a point of no return. I think Dr. Anil Arora is the right person for that, because the way he laughs, the way he keeps on smiling, he does the cemented hip with that smiling and with ease. Professor Anil Arora, please.
Thank you very much. Very good noon to all my colleagues and friends. After illustrious lecture by Dr. Harish Bhende, I think there's going to be some overlapping in statements. Just sharing with you one of my own case done about 20 years back. This was done in 1995, and this is an X-ray of 2015, a cemented hip, the poor man's hip. And that's the X-ray at 25 years. Am I audible clearly, Dr. Anand? Hello? Yeah, is my screen visible? More option, yes. Say again, please. Yes. And I'm not able to listen, not very clear. Is it okay? Okay, thank you very much for guiding me. Thanks a lot. So just to share with you that if done well, a cemented hip can last more than 2 decades easily. And just a small reminder that it's going to be just only tips, not the whole sequence of doing a cemented THR. So it's better if surgeon himself positions the patient and the desirable to have a hypotensive anesthesia, especially at the time of cementing. And if it's better you tell your anesthetist. Undoubtedly, bone preparation in cemented THR is critical for long-term survival. The aim is to have a clean, stable bony bed for robust cement interdigitation so that you can have a stable interface on either side of cement. A good surgery begins with good exposure, as Dr. Bhende outlined, and it's better to see the margins of the stubulum clearly because you are going to work in it with cemented cup. Better to expose tile if you can and reach the true floor of acetabulum by removing these, the so-called curtain osteophytes, so that you can medialize the cup adequately. One can use osteotome or curved goose to remove these curtain osteophytes and reach the true floor, or if there are large osteophytes, one can use a small reamer to remedially to reach the true floor. Just to share with you a pitfall, if you do not do so, your cup can be up and out, and it's desirable to have cup medialized and near the teardrop. Partially remove very large osteophytes to facilitate access to the socket, but however, as Dr. Bhende also said, preserve rim osteophyte because they help in pressurization of the cement, and one can remove the latter when you are checking for impingement. Enlarge the socket in the desired direction, but it's highly desirable that you preserve the subchondral bone plate partially to leave the structural support largely intact.
Yes, sir.
And the ream, by feeling the anterior and posterior walls, And usually it is 2 millimeter more on either side. That's about 4 millimeter than the initial anterior-posterior diameter. Trial cup size is usually again 4 millimeters smaller than the last reamer use. It is wise to put the trial cup, and one should be able to rotate the cup with 2 fingers very easily. That will ensure good cement mantle all around. Rehearse with the handle. If you are going to use the handle to hold the cup to put it in the place, you would know how the handle looks like when you want to put the cup in proper inclination and desired anteversion. Use drill bit to make anchoring holes. The so-called classical traditional large holes in pubis and ischium are no more desirable. You make small holes with using a flexible drill or a straight drill. Pulse lavage is must, should be copious and thorough so that you can see a clean, stable, bony, cancellous bed. One can use hydrogen peroxide, and this way you remove all debris, blood and bone marrow and fat to have a good bed for cementation. Now, a few facts on cementation. It is very clear that the quality of cementing definitely affects the longevity of the implants. And with increased depth of cement penetration, the strength of cement bone interface is enhanced. And let me remind you, very less discussed is cement. Cement is also an implant. And on the use of bone cement, we have 4 phases: mixing phase, waiting phase, working phase, and setting phase. And we all should have an idea of the duration of each phase for a particular cement at a particular temperature you are going to use. So have a clear idea of each phase of the cement you are going to use. On acetabular side, the cement application is put in a slightly later phase, in higher viscosity phase, and one should avoid mixing blood with the cement. This is going to reduce the strength of cement. Pressurize the cement. It is must to pressurize the cement, and one can use commercially available pressurizer, or one can use gauze in the glove and pressurize with this gauze and glove to get good pressurization into the cancellous bone. Prevent inferior block, remove cement from the tile area, and one should be careful to position the acetabulum component in late phase of cement polymerization. The cup should not be regarded as a pressurizer. You have to pressurize it separately initially. Know the kind of cemented cup you are going to use. You can use a handle, or you can use this kind of maneuver by free hand, and then this kind of maneuver by rotating the cup. It prevents thin cement mantles in the superior part of the acetabular dome. Avoid bottoming by putting too much of pressure. We want cement on the inner side as well. Check for the stability. Once you have cemented the cup, it is must to check stability on table. And now, whatever osteophytes are remaining, look for impingement and remove them. This is the kind of cementation you would like to have. You would like to look on an X-ray. Good cementation in the cancellous bone and good placement. So friends, adequate exposure, meticulous bone bed preparation, thorough cleansing with pulsatile lavage, sustained cement pressurization, and accurate implant positioning will ensure longevity of the cemented cup. On the femoral side, what are we looking for? We are looking for a femoral component centered with circumferential cement mantle of approximately 2 millimeter on all the sides, with a cement mantle free of defects. And we want to optimize the implant cement and cement bone interface. How do we do it? I think it starts from opening the femoral canal. And as Dr. Bhinde pointed out, exact choice of point of entry is of crucial importance for later stem alignment. It has to be posterior and lateral. The common mistake a novice can make is entering from the center of the femoral neck, the cut area. Now let's have a look how it should be in sagittal plane. This is right femora. If you enter from center, you will go and hit the posterior cortex. This can happen if you enter from the center of femoral neck rather than posterior lateral. And that's for an uncemented stem also. Now, if you enter from the posterior lateral area, you will go to the center of the medullary canal, and you will have good centralization of the stem. And that's if you are entering from the posterolateral area, you will have an area of cancellous bone anteriorly, and you know that's the correct entry point. And that's for an uncemented stem also. Now, why it is so? That's a dried femora, and that's the brooch. If you enter from the center of the femoral neck, you will go towards the posterior cortex. But if you take a brooch posteriorly and then advance, you will go in the direction of the diaphysis. Now, why it happens so? The diaphysis and the proximal metaphysis of the femur have about 15 degrees of angle. And if you wish to enter the center of the medullary canal, you have to enter a slight posteriorly to counter for this 15-degree angle. In coronal plane, it is must to remove the bone on the lateral side of the neck in the saddle area. If you don't do so, you will have varus alignment. So friends, if it is difficult to advance the initial canal finder, then most likely the point of entry is incorrect. And once you've entered the canal, preserved anterior and medial bone, cancellous bone, does tell you that you have entered from the right point of entry and you will be going toward the center of the medullary canal. In broaching, keep your handle pushed posteriorly so that it is angled anteriorly and keep it laterally pressed. Should not ream the canal too much. You should broach it. We do not want to remove all cancellous bone. We want cancellous bed for cement interdigitation and longevity of the implant. Try and aim for preservation of at least 3 millimeter cancellous bone medially and anteriorly for good cement interdigitation. Use a cement restrictor because it helps in pressurization of cement. Place it about 2 centimeters distal to the anticipated tip of stem by measuring it. And once you have done so, do not forget to keep the trial stem once again inside so that you know that you have placed it 2 centimeters distal. It will not come in your way. Pulse lavage, again, it is must to have clean, dry, bony bed, devoid of bone marrow, fat, and debris. Now, for cement mixing, do not rely on an unexperienced assistant. We do not want the assistant to mix it vigorously. It is preferable to use a cement gun to insert the cement. Mix the cement, wait till it loses luster, it becomes workable, and with one hand, apply the cement from distal to proximal. The long nozzle should not be immersed in the cement. We want the gun to come out automatically. It is in the late phase of polymerization. And if you are doing it well, the gum will automatically come out. And while you are doing so, place the thumb on the medial side. It will help in pressurization of cement. Once you have put the cement inside, use your thumb to pressurize, or you can have commercial pressurizers available along with the gun. It is desirable to use a polished tapered stem and use centralizer. It is must. It has been shown that centralization increases the likelihood of long-term success on the cemented femur. Don't hammer or don't push it hard. Don't push your centralizer very hard onto the stem. We want to allow some micromotion of the stem in the cement centralizer and then the centralizer later on. For definitive femoral stem insertion, again, you start from lateral and posterior. You put it when the cement is doughy enough, but when you're using centralizer, don't wait too late because centralizer will otherwise disrupt the cement and can cause voids and lamination here where the experience is required. You know when the cement is workable, when it has become doughy enough, and when it is not of low viscosity. Now, when you're inserting it, slight posterior pressure to direct the stem tip anteriorly with a smooth action. Insert it slowly, feeling the counter pressure with the thumb on the medial side. Insert it slowly in the line of a longitudinal axis of the femur, keeping your thumb medially. That will help in pressurization as well as it prevents varus angulation. Remove the cement, excessive cement. And please note that if you're using a stem introducer, it should hold the stem, but should not have a rigid fixation, because when you're trying to unscrew, if you're using a screwing mechanism, which is not desirable, some local companies give you a screwable mechanism onto the stem. Don't use them. because if you're trying to unscrew the stem introducer, you will transmit toggle into the stem, and that might make it loose later on. Do not hammer the stem. It is highly undesirable. When you put the stem in, you're putting it inside the canal, bone marrow extrusion is a positive intraoperative feedback for good technique for pressurization. While the cement is sitting, hold the leg and stem still. Do not introduce toggle. You do not want it to become loose later on. And once you have done so, seal the implant cement and cement bone interface. You do not want ingress of the polyparticles into the canal. The overall composite cement mantle and the medial calcar is desirable to be around 5 millimeter thick minimum. And once you have put the stem, there should be 3 zones, one of the thick cancellous bone and cement composite and the cement. This is the kind of cementation you are looking for to have a longevity of the femoral stem. Thank you very much.
Thank you, Dr. Anil Arora. I think it's a wonderful, wonderful tips and tricks, because the cementing is a thing. Looks very easy, but technically is very difficult unless until you are accustomed to it. And for a novice, I think it is a wonderful thing to learn. Now, I call upon Dr. Anil Oman from CMC Vellore, because every time when you do a THR, you won't get a full-fledged acetabulum. You may get a deficient acetabulum. And sometimes you are stuck up because when you realize that the type of acetabulum which you are demanding at the time of doing THR is not there. Then what are the ways to do it? And what are the tips and tricks to counter that problem? I think Dr. Anil T. Oman is the best person to guide us. Dr. Anil T. Oman, please.
I hope everyone can see my screen.
Sure, sir.
Yeah. Thank you very much, Dr. Prasad and the entire team for this wonderful opportunity. And my brief here would be to a very specific topic would be to cover acetabular reconstruction with augments. And as we all know, we have various situations, and after those illustrious talks right from the live surgery onwards to ideal positioning of a cemented bar, uncemented implant, we need to know, especially in the primary complex and in the revision scenario, how to take care of defects with other options. Now, I'd run my talk with more of examples to drive home the point rather than dwell on the theoretical aspect alone. This is a 38-year-old male post-op who came to us after fixation, after TOTLIP, with an infection, and obviously this had to be staged. And the big advantage of staging these procedures is the fact that you have an opportunity to assess the acetabular defect, you have an opportunity to assess what is the residual bone stock inside, and you have an ability to plan for the next surgery. And this is exactly what was done, and the CT scan definitely shows there is a posterior and a posterosuperior defect, and the typical type 3 defect that would warrant a reconstruction. And hence we proceeded with the second stage after ruling out infection after 3 months, and we put in a posterosuperior buttress, put in some allograft, reduced the cup size, and thereby reduced the center of rotation as well as reduced and restored the center of the hip. Now, in the Paprosky classification, today's talk I will be dwelling on these type 3 defects, which are the type 3 up and out, and the B, which is the up and in. And that is critical to management because either in the complex or in the revision scenario, it has to be borne in mind that the available host bone is minimum and further compromise is absolutely not possible and should not be done. And that is the stage where you would like to use an augment in order to facilitate and to use the restoration of the available host bone that is possible. And the aim, whatever method is used, is to restore that hip center of rotation and to achieve a smaller cup size as required now. And people are moving away from the jumbo cup technology. Now, this is because you can reduce the size of the hip, you can also bring down the hip center. So it is ideal to get that capture, whichever direction you may get it in, the anterior posterior, anterosuperior to posterior-inferior. Remember, it is a deficient acetabulum. So we have to aim for that cup and build on that. Now, remember the trabecular metal options that are available are from the DePuy and the Zimmer, and it's called the trabecular metal acetabular reconstruction system. And there are a variety of shapes and forms that are available, and that can be used either for the buttress effect or for the hemisphere effect itself. And classically, these are used in the type 3 defects, both for the posterior-superior absent column or for the posterior and superior defect in the column itself. Now, these type 3 defects can be managed, and definitely looking at the principles of management, we have to restore the buttress in order to be able to give a stable hip construct and thereby give an optimal functioning of the hip. Now, this is a typical example of a gentleman who came to us with this injury. He had a significant injury to the posterior and the superior wall of the acetabulum. He underwent a fixation, which was a femoral nailing and a acetabular fixation. But unfortunately, he went on to get infected, and thereby we had to do a removal of the implants in the acetabulum as well as the femoral component itself. And finally, we had to plan him for a staged reconstruction. And thereby, with that, we could see that the posterior and the superior segment was deficient, and we had to take him up for a posterior superior buttress with the fixation of the femur and achieve a stable hip center at 1 year post-op as well. A typical scenario where somebody comes to you much later, they come with this evidence of infection, already proximally migrated, already articulating proximally. Then you have to do it obviously in a staged fashion, and then planning has to be done appropriately. The CT scan will tell you that there is a lot of reactive bone present, but then we have to plan to restore that hip center, and that can again only be executed by putting that posterior superior buttress. And this was done, and in order to restore that hip center of rotation, we had to do a femoral shortening as well, and thereby restore the length as well as the vertical and the horizontal offset. Again, another gentleman, common scenario, they come to us post-acetabular fixation. Common scenario even we have had where they do develop infection, especially in the polytrauma scenario. There we have the situation where you have a posterior superior defect suitable for a hemispherical augment, and there put the buttress in place. Remember, a small amount of cement between the shell and the augment is absolutely mandatory to prevent that micromotion, and thereby you can get a stable fixation by getting that buttress and getting a stable fixation for the cup as well. This is a 66-year-old male, 18-year post-op, again with loosening, the revision scenario. A CT scan would actually throw out and actually put forward so much of information about the acetabular defect. Again, the superior and the posterior wall deficiency restored by the buttress, and a revision done, again seen at follow-up, doing quite well. This was a lady who came to us 2 years post-op with this fixation done elsewhere, and she had a dislocation. And when we did a CT scan, we realized that the anteversion also was not correct, not optimal, and the augment also was not seated too correctly. This lady required a correction of that inclination and the anteversion, and the augment was left in place. However, the cup was redone, and thereby we did a conservative revision and achieved a good result in this lady itself. This again is a gentleman post-trauma who had a significant posterior-superior deficiency, comminuted fracture, came to us delayed. Again, the ideal situation for a posterior-superior buttress and a restoration of that hip center. Now, this gentleman came 1 year post-op, again a similar scenario, with only difference here being the acetabular fracture was fixed, and there is a doubt, or there is always a doubt in these situations regarding the union of the fracture or a frank pelvic discontinuity itself. So the nail was removed, and the first stage, because there was no evidence of infection, a refixation of the column was done, but that had to be again fixed back at the time of revision, and achieving union was only possible with a little bit of impaction bone grafting and this buttress and a cup impacted in position to achieve the stable component again. 64-year-old male, again post-acetabular fracture fixation, again with the posterior superior defect, ideal for a posterior superior small hemispherical augment, which was able to restore again the center of rotation, able to use a smaller size cup and achieve a stable fixation intraoperatively. Another gentleman post-fixation, again the implants were removed, again a hemi-augment was used. We had to refix the cup, the column itself with another plate, and thereby achieve this amount of fixation post-operatively. 34-year-old male who came 13 years post-op, taking out the implant itself was a challenge. the medial defect options were managed with a acetabular augment on the medial side, and thereby this was restored. Even though the offset was not restored optimally, there was some restoration of the horizontal and the vertical offset, and the ETO had also begun to unite at 10 months post-op itself. This was a lady who came to us 2 months after a THR following a fracture neck of femur. The acetabulum had loosened out, and we got a CT scan that had revealed that the cup, this was just 2 months post-op, and that had caused a significant erosion of the posterior-superior wall. And this is a significant pattern that we see, especially with loosening, and the whole buttress had been lost again. This was revised with a larger cup, and again with the posterior-superior buttress with multiple screw fixation, and this again was seen as a stable fixation. And this again, this lady is just about 6 months post-op, and we got her first x-rays just recently. 57-year-old lady, again, a type 3B defect due to a cemented cup loosening. Type 3B, femur was preserved. We did not revise the femur. All what we did is we put in a hemi-augment, got that smaller cup, restored the hip center, and restored the vertical and the horizontal offset. Another young gentleman who came to us following this acetabular fracture, again with a fixation or with revision, basically situation having issue for a posterior-superior defect, implants in place. We definitely went ahead with fixation, went ahead with removal of the implant, and a staged reconstruction with the posterior-superior buttress. Also required a femoral shortening to restore that offset. So the message, especially the focus of this talk, was the role of augments is a very, very crucial element in planning, especially in complex THRs and one with the posterior-superior augment or posterior-superior defect. The planning would be with a 3D reconstruction or a CT scan or even a 3D model if possible. Indications are very specific. And remember, whatever we use, it is to restore that hip center, reduce the size of the cup, and the technique is absolutely essential. Thank you once again, Dr. Prasad. Thank you all for this opportunity, and good day.
Thank you, Professor Oman, for a nice lucid talk. I think these are the things which can save us at a time of crisis. Now here we are, this session is open for discussion. Now, my first question is to Dr. B.D. Chatterjee.
Yes, please.
Yes, Dr. Chatterjee. The first thing is that, do you change the anti-version with different approaches? Or that area, the change, because sometimes it has been taught that the change of the amount of anti-version should be seen at the time, should be considered when you choose an approach. What is your opinion about it?
So there is a tendency, if you use the anterolateral approach, to over-antivert the acetabulum.
Right.
And the opposite is true when you use a posterior approach, that you tend to retrovert the acetabulum. So I do not think that you cannot choose different approaches if you want to change your antiversion. All I'm saying is that when you are using the posterior approach, be sure you can actually err on the side of increased antiversion rather than reduced antiversion. And the opposite is true for anterior approach or anterolateral approach, where you should avoid the tendency to over-antivert. So like what Professor Malhotra said, bring your hand down so that your socket goes into the proper version. And in the posterior approach, sometimes the femur gets in the way. So then that tends to retrovert the socket. So you need to get the femur retracted well out of the way. And then there are various ways of doing it. You can aim for the opposite shoulder, or you can look at the TL and all that. Yeah.
I think that's wonderful. How do you rate the myocutaneous flap with a Ranawat suture? Both the things are being propagated differently.
So,
your posterior approach and the rate of propagation.
So there are two thoughts on this. One school of thought is to repair the capsule and the muscles separately. But, I was taught by Ranawat to take it as just one flap. Yeah. And I think that is a benefit, because if you dissect in between, it sort of causes a lot of fraying and the tissues become non-viable. Whereas if you take it as one complete flap, it's a nice solid chunk of tissue which you can anchor very well. to the trochanteric crest posteriorly by taking pull-through sutures. So in my opinion, that's the preferred technique. And I think that good secure repair has dramatically improved outcomes in posterior approach and dramatically reduced dislocation rates.
All right. Any questions from the panelists?
Right. Dr. Chatterjee, you have rightly discussed about the various approaches, but have you taken into considerations where an earlier surgery has been performed, may not be a total joint replacement, maybe for a fracture fixation, maybe for some disease like rheumatoid or even tuberculosis. So then how it modifies your approach?
Yeah, so thank you for the question. And it was very nice to meet up again after a long time with you, sir. So I think you need to consider what is the nature of the surgery that has been done before and what has been the outcome of that surgery. Now, is it a arthroplasty or a non-arthroplasty? And if it was a non-arthroplasty, was it due to an infective etiology or a non-infective etiology? Now, if it was an infective etiology, and particularly if it was tuberculosis, traditionally tuberculosis surgeries were recommended to be done anteriorly. So in fact, I still remember the anterior, Wilkinson's joint debridement, all that we used to go through the Smith-Peterson approach. So those were during my postgraduate days. So I think in those cases, it is better to avoid that area because that will be extremely fibrotic with distorted anatomy and you may not be able to really find your way through. So it is better to go in a different way. On the other hand, if there has been an arthroplasty which has already been done through a particular approach, I think it will probably be wiser to use that same approach because supposing one THR has been done anteriorly and you want to revise it, and especially if the duration hasn't been that long. If it's been several years, then probably doesn't matter. But if it's a fairly recent one and you want to revise it, then it's probably better to use that particular approach again. On the other hand, if it is something which has been done several years ago, 10 years or 15 years ago, then probably it doesn't matter so much. So that's what I would say.
Dr. Chatterjee.
Yes.
Dr. Jakub, please go ahead.
Yes.
Then I will ask.
Yeah, hello.
So if there is a presence of an approach, the dictum should be a presence of an incision, go through the same incision if it is not difficult.
And it is not a non-infective. Yeah.
Right. Definitely.
And number two, you have gone into studies showing the difference of rates of dislocation through various approaches. So where will it be different depending on the number of cases performed by an individual surgeon?
Yeah, I think so. I mean, if you have done a great many surgeries through a particular approach, then the chances are that you will have a very good result using the same approach. All the recent studies have shown that the bugbear of the posterior approach, which was posterior dislocation, has now, very much it has been addressed. Therefore, all the recent studies have shown less than 1% dislocation in a posterior approach. So I don't think that should be a cause to change your, a decision to abandon the posterior approach.
Since majority of the surgeons are used to posterior approaches, would we like our younger generation to switch over to something else and maybe the direct anterior one?
So, you see, that's what I said, that this is a somewhat sensitive topic and each one is very fond of his or her particular approach. So my first advice is that please do not be dogmatic. I think it is wrong to say that this is good and this is bad and this is too good and this is not so good. So I think we should avoid being dogmatic. Every approach is good. Every approach has a few difficulties.
Yes.
So my advice, then this is again purely my advice. I'm sure other people will have other opinions. So what I would say to young surgeons is that stick to what you have been trained, get better at it. If you have been trained in the anterolateral approach, get better at it. Keep on doing it until you get better. It is good if you know one other approach, which you might in very rare circumstances be called upon to use. So yeah, so if you're mainly an anterior approach person, but get some idea of the posterior approach, because there may be situations, particularly in revisions or where you have planned an extended trochanteric osteotomy, then you might want to use the posterior approach. So that will be my advice. Anterior approach, well, of course, I mean, if you tried it out and you're comfortable with it, then there's no problem with it. Personally,
Right,
I found that it's a pretty steep learning curve. So I don't know. I mean, that's why.
Once I was doing an anterior approach, and Dr. Ranawat was there. He said that is a difficult way of doing a simple thing.
Yeah. So that's one way of looking at it. But
I think Chatterjee's approach is definitely that one should know the two approaches, because then I explained to him that the patient had a bed sore at that time, that I could not approach by the posterior approach. That's why I was doing the anterior approach. That's why that Dr. Chatterjee's dictum is definitely good, that one should know the two approaches and should be equally comfortable with these two approaches, so that he should have a via media while doing the surgery at that moment of time. Katie, do you want to say something?
Yeah. Dr. Chatterjee, if it is a simple hip, you can go ahead with the posterior approach or Harding or anterior approach, maybe anyone. But if there is a deformity like ankylosed or fused hip in the flexion adduction or flexion abduction, and if there is a severe protrusion like grade 3 or 4, then do you want to suggest that which approach should be easier?
You see, that's what I said. It's something like that PSCR debate, which never ends. If you ask me, I do 98% of my cases through posterior approach, and I can do anything with the posterior approach. But that doesn't mean that other people cannot do the same thing with an anterior approach. So I don't know. Maybe Harish, what would you like to say?
Flexion abduction and flexion adduction contracture.
Days, maybe couple of weeks, that benefit is technically gone. Everything remains same. So rather than trying to worry more about approaches, we should worry about how to implant the component in securely and get orientation and offset neckline balance better. So you should do what you are comfortable with.
So that's what the papers say, that at the end of 6 months they are all the same.
Yes. Omen, your comments.
Yes, I just wanted to add one thing. See, I'm using the anterolateral approach as a routine approach, and that actually works well for all the straightforward hips. But only caveat there is, like BDC said, and even Harish Bende, I think we have to stress on the fact we have to get the component right. And if it requires a posterior reconstruction, I cannot do that through the anterolateral approach. I have to go posterior at that time. So it's better to know both. And Dr. Jha also told us about the previous surgery. If the previous surgery is also through a posterior approach, then I think there's all the more reason to go through a posterior. Say, suppose the previous bipolar, we can go through a posterior approach itself. Unless and the versatility of the posterior approach, I think Dr. Chatterjee has brought out very well, because you can do all the posterior reconstruction, everything through that. Anterolateral, for us who have trained with anterolateral straightforward hips, which do not require posterolateral reconstruction or posterior reconstruction, and all the others, even with protrusion, everything, and in fact, even for fused hips, ankylosed, we routinely do through the anterolateral approach.
You will be able to reconstruct all the defects of acetabulum through anterolateral approach?
No, that's what I said. When there's a posterior acetabular defect, and when your posterior column requires fixation, when you require augments, that cannot be done through the anterolateral. That has to be done through the posterior approach.
I think that. Sometimes, Anil, sometimes you get, after doing an Austin Moore prosthesis, and you get a late cases, you get an eggshell type of acetabulum, where you don't have anything anywhere, and the bone quality is too bad in a 70 years old individual. What is your choice of doing an acetabulum augmentation in those patients and doing a THR?
There would be more in favor of putting in an augment, not just an augment. You may have to put in a true cup cage construct. Because there the problem is we have to do a CT scan and also establish that there is no pelvic discontinuity. If that is the case, there are two things. Either use a cup cage construct or use a redapt type of cup construct, where you can have a 3-point fixation, where you can have one in the superior acetabular roof, one on the ramus, and one inferiorly. and you can cement in whatever implant you want with the cemented liner, and use a dual mobility also.
How much is your 3D reconstruction helps to you to reconstruct the acetabulum in these type of cases? Any acetabular defect whatsoever I'm talking.
The CT has become definitely a must, especially when you're planning a revision. So when you're doing a 3D reconstruction, might not necessarily translate into a model, but the 3D reconstruction gives you a lot of information about where you want to put that implant in. And like I said, it will give you an idea, a fair idea where you would like to put the cup, where you would like to put an augment, and you can keep all the options on table once you've adequately prepared.
Right. Harish, how much templating is going to help? Because you are the person who taught me the templating in 2003.
The templating is basically a guideline. We actually don't use templating for all our patients. But if you find a patient which is very small, very thin, or a young patient with a very good cortices, where sometimes you may end up using the thinnest implant, or the acetabulum is very narrow or very small, then you must do templating with a proper templating and proper magnification scale on the side of your X-ray. If you have proper magnification scale, you know exactly what implant you need to use. And sometimes, especially in small females, you may end up using cup which is maybe 38. And not all companies will give you a cup which is size 38 or 40. You have to specifically ask for them. So these extreme cases, which are either too big or too small, or those which has got a deformity in a cup or some defect in acetabulum, templating will help you to understand exactly what implant you are looking for and keeping ready for those things. But in the routine standard case, with there is no significant deformity, you may not do templating. I mean, I know it's a teaching session, you said templating in all, but it doesn't happen in a real practice. So we do template in about 20% of my cases, but 80% which are standard routine cases, young patient, good quality bone, average height, average dimension, then we don't worry about templating. What we do more is intra-op measurement. And that intra-op measurement includes the limb length measurement as done by Ranawat using the infra-acetabular Steinmann pin, which gives you accurate idea about whether you are lengthening or shortening the particular hip. Number 2 is measurement of where your cup is going to go in. That with respect to your TAL, if it is on the TL, then probably you are not changing the cup and change the cup going up or mediolateral. And number 3 is the measurement of offset neck length on table before you cut the head of the femur. So if you have these 3 measurements, intra-op leg length, intra-op acetabular placement, and intra-op offset neck length on the femur before you cut the femur, 80% cases you do not need to do templating, and you can still get very accurate reconstruction of your damaged acetabulum and damaged femur.
Yes, sir. I think one thing you have shown in your film also about the osteophytes. That for a novice, I think it is an important thing. I want to again reiterate it, that sometimes what a novice do is that the moment he opens it, he removes all the osteophytes and start then putting a cup and measuring it. What's your take on hemostasis for the youngsters regarding the acetabular osteophytes?
As I mentioned, when you dislocate the hip, remove the femoral head, expose the acetabulum. If there are small osteophyte, maybe within say few millimeters, I keep them, I rim the cup and I put the cup, primary trial cup, and then actual cup with a liner. And beyond that, if the acetabulum osteophytes are protruding and coming in a way, then only I remove them. Because many times, especially in younger female patient, I do get a lot of young female which require, because of avian or some other thing, THR, and they have a little shallower acetabulum. And these small osteophyte may actually help to get an adequate fit of your acetabular cup in a primary non-cemented THR. You should remove them beforehand.
I think that's a good one. Now, Professor Anil Arora. Are you here, sir?
I am here, very much here.
So the very thing is important, you use a cement gun and previously we used by a thumb impression. How much difference have you realized after doing this? Because we people are there, we are trained in both the cases. We started with thumbs and now we have got a gun. But for a youngsters, everybody want guns and they want that if they don't have gun, they can't do THR. But previously we used to do it. What is your message for the youngsters and the persons who are using guns and they are tuned to the thumb?
So it is highly desirable that you should use gun. Literature has proved that the cementing affects longevity, and you can do better cementing with gun when you do retrograde filling and there are no air bubbles or the cement does not have any void. So for the youngsters, message is, this is the good for good cementing. It is must to have gun. One should strive for gun undoubtedly, and that is type 1 cementing when you use fingers only. Type 3 cementing is when you use gun, you use cement restrictor, you do pulse lavage and do retrograde filling and pressurize the cement.
Right.
So answering your question, it is highly desirable to have cement done for longevity of implants.
Dr. Anil, how to pressurize on the acetabulum side? What method you use? Is there any by the hand pressurization or you had some company-made pressurizers?
So you have in Exeter, if you see Exeter instrument set, you have pressurizer available. But if not, then you use a glove, fill it with gauges, and it becomes a pressurizer. I showed you in the picture. With a glove filled with gauge, you can pressurize. It's a wide mouth, so you cannot pressurize by thumb. You need to have something bigger and elastic. So the gauze inside the gloves can help you as a pressurizer.
And also
Must to
sometimes,
pressurize. It is must to pressurize. Don't take cup as a pressurizer. It is a very common mistake to take cup as a pressurizer.
right. Sometimes in patients in whom the DHS was done and the THR has to be done and you remove the DHR and plate. Then at that point of time, what is your take on these type of cases? How to do a cementing, sir?
So there are few techniques to prevent cement leakage from them. For the time being, you can put those screws back for 2 or 3 threads only, or put a scale on the outer side, or you can ask your assistant to put thumbs on those holes. You want to prevent cement to egress out of those holes. So these are few techniques to have better pressurization if there are pre-existing holes on the femur on the lateral side.
Okay. Any questions from the house?
Dr. Arora,
Yes, sir.
while you are reaming the acetabulum,
Hello. There is no voice.
Yeah.
There is no voice.
Yeah, I think Dr. Jha's internet has gone. So.
There's net connections.
Sir, may I ask Dr. Vishal Agrawal from Dr. Anil Arora?
Dr. Vishal, good afternoon. How are you?
Good afternoon, sir. Nice to have you back here.
Yes, same here.
Sir, you said to use 2 threads on the outer side, on the outer cortex, to prevent leakage of the cement once the DHS is revised to a THR. What about the medial cortex? It is not approachable easily either for anybody to put a thumb or anything.
Yeah, so that some amount of cement will definitely seep out from those areas.
Okay.
You want to minimize it. You cannot eliminate it.
Yes, sir. This is what I wanted to know. Yeah. Thank you.
Dr. Oman. Are you here, sir? Dr. Professor Anil Oman, are you with us?
Sorry, I just unmuted myself. Sorry, very much there.
So sometimes in case there was an acetabular defect, it was fixed. And you found that the defect on the other side of the acetabulum also when you were doing a THR. That fracture was fixed previously done by somebody else. And you are doing a THR, there was a defect on the other part. Suppose the posterior part was fixed, there was a defect on the anterior part also, anterior pillar. And the parts were well united. Do you remove that implant or you use the augment only to fix that anterior part?
No. The implant removal following an acetabular fracture fixation only for infection, number 1. Number 2 is also nothing, if it doesn't interfere with your fixation of the augments or doesn't interfere with fixation of the other fragments, we do not go behind it because that will be always in scar tissue and risk of nerve injury is very huge.
Okay. That's basically a message I want. Anything from Dr. Prashad? Your take?
Nothing. I'm just enjoying. It's a beautiful session. I would like to just comment one thing. Nothing extra. I think this was the best session. Everyone has come out with so much of good inputs. I would prefer that anyone who is going for a hip replacement must watch these lectures again. All people in approaches by Dr. Chatterjee, the uncemented by Dr. Bende and cemented by Dr. Arora has given us all the tips and the red flags which we must watch during surgery. And it needs revision for every surgery. It was really interesting to see the points, small points, which can make your outcome better. And Dr. Anil Oman, what she has shown is the variety of things which can be used to get a better outcome. And the concept again, you have to get the center of rotation right. Your whole endeavor is to get it there. And what are the tools to get it there? He has shown. The variety was tremendous. I'm really impressed with this session. I was absolutely watching an A of the points Dr. Harish Bende has shown, Dr. Anil Arora has shown, and the beautiful depiction, beautiful pictures they have. Lovely. And thanks, Anil, such a variety. I do revision, but I have not used so much of argument, and that too so successfully. So I'm very happy with the session.
So Anil Oman, I think, given us a parachute, if we have dropped from an aircraft, how to use a parachute. That's the most important part, because sometimes we kept aloof what to do. I think he has given a lot of horizon on how to land and solve that shit.
Yeah, I think we have had the privilege of having the complex cases, a lot of them over the years. So I think that has given us an exposure to all these varieties. We are privileged to have that.
But sir, we are blessed to have the knowledge with you also. Because these things, sometimes we don't think about it, and you have given us the idea that we can do that. It can be done, rather it can be done. Right. Anything?
Thank you, sir. Thank you.
I would like to re-emphasize. Number one was for exposure. The point which was said, you can err in the antiversion if you are adept at one exposure, you are trying to change your exposure. So that was the point Dr. B.D. Chatterjee said. So if you're doing regularly a posterior approach and you switch to anterior approach, then you can err on the side of antiversion something. Number two, yes, you must know how to approach the hip differently. You may be practicing one approach, like in ankylosing cases which are fixed in abduction and external rotation. We can use a hardening where we go anteriorly, do a osteotomy of the neck from anterior side, and you may perform the whole surgery from the posterior side if you are not comfortably doing it from the anterior side. But we must know how to access the neck from both anterior and posterior. Similarly, a surgeon who is doing anterior approach, if he gets a case where there is some problem in the posterior part, how he is going to do that? So these are the points which are very, very important, and every surgeon must try to learn. We all have done that. We all have learned the same way. So it is nothing like impossible. It is simply doable. The only thing the surgeon has to have the intent of learning that. That's all.
I think we should wind up this session now. We should start with the next session. And thank you for all the faculties, panelists, and speakers. I think we have learned a lot. It's right, read or retire. We are reading and we are learning. It is like pedaling a bicycle, either going ahead or falling down. And with this knowledge, I think we should keep on working in silence. Let our work should make the sound. Thank you everyone for this being a nice session with us. Now over to Vishal Agarwal.
Thank you, everybody.
Thank you, everybody.
Dr. Nigam.
Thank you.
Vishal, thank you.
Thank you, sir. Thank you. Now I'd like to invite the person who needs no introduction, Dr. S. Prasad, and I am very proud to have you as my mentor, sir. Welcome as moderator to the next session. Dr. B.D. Chatterjee, once again, happy birthday in advance. Dr. Anil Arora, sir, a frequent visitor to our conference, a known face, and a very good guide. Dr. Sandeep Gupta, Group Captain from Air Force from Lucknow, and our own, the face which is not seen, the person at the OT table always in the live surgeries, Dr. Amit Verma from Kanpur. Handing over the proceedings to you, Dr. S. Prasad, sir.
Hi, everyone. The team of panelists is absolutely brilliant. We all are familiar with each other. I just would like to add Professor Jha here so that This again a award session. So Dr. Jha is looking after that department. So I would request Professor Jha if he has logged in again. There was some issue with his internet connection.
Right. Thank you.
And we'll go for the case discussion. And again, I'm still in awe with the last session. I still will say the recordings will be there and it is available on YouTube. So any surgeon who wants to go planning a surgery, please go there. Watch the tip from Dr. Bende, watch the tip from Dr. Anil Arora, and then do the surgery. It will refresh the things you are going to take care during the operation theatre. There's a lovely lecture we had. Now we are going to have an array of case discussion with so much of panelists, and still I welcome all my faculty, the esteemed faculty. If they are there, their input on the case discussion is most welcome. And we have got a lot of viewers from all over India. That's the beauty of a Zoom platform or a virtual platform, and also abroad. So let's go for cases. The first case is by Dr. Mrinal Sharma, who was a very excellent moderator yesterday in the cases of knee. Dr. Mrinal Sharma, please share your screen.
Sure. Thanks for giving me the honor. I just wanted to share my experience of one of the cases which gave me goosebumps, and I'll be sharing my screen. Are you able to see my screen?
Not yet.
Now?
We can see that.
Yes. Okay, so this is a patient whom I have done a revision, but he was operated earlier 4 or 5 times. So I'll go with the history of the case and let us see what our panelists have to say about it. So this is a 40-year female actually who had an RTA on 19th of June 2019. And she had a both column fracture with a transverse type of fracture, which was fixed somewhere. What the surgeon actually missed was probably an impacted fracture of the femoral head. That is what I have seen on the retrospective analysis of the X-rays she had. And she was operated, and the first anterior column plating was done, and 3 days later, the posterior column plating was done. Now, she says she had a history of fall, but I personally feel that probably the surgeon who had missed the impacted fracture also missed the fracture neck of femur in this patient. So should we go for a discussion, or should I go ahead with my presentation and, Dr. Prashad, can you unmute yourself?
I think we can go ahead and do the whole case, then let the panelists ask.
Yes. So the plan of action was, see, this is a case which was operated somewhere else, and this is what the surgeon did. They did a total hip, and you can see on the X-ray itself that the cup was vertically placed. It was already, retroverted on the CT scan, which I could gather from the patient. Although it was well fixed, but still, a malpositioned cup is a recipe for failure. We all know that. And they've used a dual mobility, but I didn't feel that it is actually a panacea for a very malpositioned cup. And so ultimately, it started to fail. So this is the 3 months down the line, she came to me. This is when I first saw her, and I told her it is going to fail. And what I could appreciate on the X-rays was that probably the fracture site, which had been fixed with the plates, was actually showing an opening. And I could make out that this is going to fail. And although the cup was sitting well and on the CT, this is 3 months down the line when she again came to me, and you can see that the cup has rotated, and you can see a huge defect in the acetabulum. And I could make out that probably there is some kind of a pelvic discontinuity. Although the CT scan doesn't show, it does show the floor is there, but it was a mobile fragment intraoperatively, and the ilium and the ischium were altogether separated during the surgery. So I ruled out the infection. So my options were 3 when I discussed this, but probably I would be dealing with pelvic discontinuity. I kept an option of custom flange cups, a cup cage construct, but then the cost was a bigger concern for the patient, and the distraction technique, which has been mentioned along with the use of Gription or TMAS cups and jumbo cups. But again, the cost could have been a concern. So this is the intraoperative picture. You can see the dual mobility, cup. I have removed the components and I could see a huge defect. I don't have a zoomed in picture of the defect intraoperatively, but there was mobility. Despite plates being there in the posterior anterior column, I could see the defect in the floor, and I had to I roared that area. I decided to put in an allograft, and you can see I have used allograft which is available in my hospital from another hospital, Sant Paramanand, from Dr. Shekhar Agarwal's hospital, which I get it from there. And I did the impaction grafting after having made the area of the discontinuity and the pelvic floor raw so that the graft would incorporate. I also drilled up the sclerotic bone all along the bone which was available. And this is the, you can't say it's a customized cup, it is available there. It's a gap to restoration, which I used. And, I saw it intraoperatively with the C-arm, the placement, and you can see the screws going directly into the supraacetabular area, as well as I had used screws in the ischium as well, so that I do not have any abduction failure and the cup is stable. And I then did a cementing. So this is the cementing of the large diameter cemented cup from Stryker, and I have unitized this along with the cage onto the ilium. So that is very important because that prevents, the rocket motion if the cup is not unitized with the ilium, and that prevents early failure. And I've also put in 2 or 3 screws in the ischium so that I don't have any mobility and the cup is a stable construct with the cage. This is so you saw the immediate post-op X-ray, and this is like 6 to 8 months down the line, and you can see that the graft seems to be incorporated. And this is a recent follow-up of almost 2 years now, and the graft, the allograft has incorporated. It's a stable cup. The patient is mobilizing well. So the take-home message would be that restoration of bony anatomy and bony support is of utmost importance. You can't just leave the ilium and the ischium hanging in air. Dual mobility is no panacea for malpositioned cups. And impaction bone grafting with cages is one of the options apart from cup cage construct and the distraction technique with the larger jumbo cups for pelvic discontinuity. Thank you. So any questions from the panelists?
Mrinal,
Yes,
good
sir.
afternoon.
Good afternoon, sir.
Can I ask just one question, just clarification?
Yes, sir.
Mrinal, what is the age of the patient?
48, 49, sir.
49. And you did a great job, undoubtedly. It was a very difficult situation. You came out of the difficult situation very, very well, undoubtedly. Now, the kind of cage you have used, is the outer surface osteoinductive or osteoconductive, or it is inert?
No, it's not osteoconductive.
Osteoconductive. Yeah. So for the benefit of delegates, I want to bring out only one thing with these cages. These kind of cages, they are bailout situation. I think preferable is what you said, is a cup cage construct so that you can have an osteoconductive and osteoinductive outer surface, so that there is continuity and it gets incorporated. This was a difficult distress situation where you came out with a cage which does not have an osteoconductive or osteoinductive property. And with passage of time, she's quite a young patient. We expect this cage to fail in 10 years, maybe 15 years down the line. But by that time, you have restored the bone stock for future revision. Did a great job. Just want to highlight one point, that these cages have high loosening rate in 5 to 10 years follow-up because they do not have any osteoinductive property on the outer surface.
Yeah, I do agree, sir. And definitely there was a cost concern because
I agree.
The cup cage construct, the cost goes out around 1.5 to 2.
No,
We are in the same boat.
Mrinal, you have done a
Fantastic job. Fantastic job.
Thank you, sir.
We are in the same boat.
Yes, sir.
It was a very difficult situation. You came out very, very well. And I can imagine, because I also do revision surgeries, how difficult it would have been to handle all this.
yeah.
The best thing is I can see the new bone has formed now on the acetabulum. That is the best thing.
Perfect. The best part with these cages is that if you fix them well, they restore, and if you have grafted the outer surface, you restore bone stock for future. You've done a great job.
I think the grafting was a masterpiece, and that has given all the beautiful things. And you brought the center of rotation so well. That's wonderful surgery.
Undoubtedly beautiful.
Well, Mrinal, you had circumferential wires in the femur.
Stop sharing the slide, so we all panelists can be there.
Yeah, sure, sir.
Okay, Mrinal.
Yes, sir.
Yes. When the patient came to you, it had circumferential wires in the femur.
Yes, sir. Because
yes.
there was one incident of a dislocation and it was reduced, and probably she also had a fracture when they tried to do that, and they put in the wiring. So that is why she came to me after the 5th surgery.
Right. So when you were reducing it on your own operation table, were you apprehensive that the cemented stem might become loose?
Sir, it was a well-fixed stem in the correct position. So I had no apprehensions. I had kept everything ready for the stem to be revised, but I have not revised the stem.
Okay.
Any other questions?
I think very well managed case. Theoretically, in this sort of pelvic discontinuity, there are three options: the tri-flanged cup, the cup cage construct, and the distraction technique with the jumbo cup. And I think he has done a wonderful job with the available resources. So theoretically, of course, a tri-flanged cup would have probably been a more secure fixation, but that's far more costly, expensive.
But with the impaction grafting, it has. And Dr. Anil there, because he can give his options also. If Dr. Anil is here.
Anil Umen.
Anil Umen, yeah, sorry.
No, but I must congratulate Mrinal. Very well done job, undoubtedly. Mrinal, theoretically speaking, I just want to have one question if you can answer.
Yes.
So would there be a situation where you cannot do distraction technique depending on mobility of fragments? It is too wobbly to think of doing a distraction technique. And I think there has to be strong fibrous union to do a distraction technique. What do you say?
Definitely, sir. There are situations, I personally don't have any experience of doing distraction technique, but whosoever is using, they would probably not be able to use it if the pelvis is not budging. You know, if you're not able to get that compression once you've done the distraction, then you won't be able to use this technique. You will need a cup cage construct.
Fantastic.
That's true. The conceptually is absolutely right.
She's done a great job, so no questions, sir.
Yeah. So let's go for next case. And thanks, Mrinal.
Thank you, sir.
You rock again. So the next case is by Dr. Sarup Patel. Again, a very young and very dashing joint replacement surgeon. He's from Varanasi. Dr. Patel, you may share your slides.
Thank you for the kind words, sir. And here's the case. I hope my screen is visible now.
Yeah, it is.
Yeah. So this is a case of bilateral total hip arthroplasty done by a direct anterior approach. So I did this 2 years back. I was very new for this approach, but as we all were discussing about the approaches, I thought I should know few more approaches apart from the posterior approach we regularly do. So this is a 17-year-old male. He has bilateral AVN. He had ankylosing spondylitis, and the patient was on, he had pain in both the hips for around 1.5 years. He was on medication, but he was not very significantly relieved, and there was a cost constraint. So this was his X-ray when he came to us. So this is the right side and this is the left side. So what I decided, because he was in so much of pain, he was unable to walk, family was little worried. So no other option was left. So I planned for a total hip arthroplasty. He was very young, so I wanted to do an anterior approach rather than the posterior approach, so that I can give him more freedom of walking and doing all activities. And so uncemented metal on poly was planned. So this is just few photographs to show. Professor Malhotra showed it very well today morning. So this was in right side. So we dislocated the hip, the head is out. So once we cut the neck, we can see the acetabulum very well, and we can rim it. Rimming technique has been shown by Sir and the tips and tricks. So once you are rimming, the best thing is to have a C-arm view, because as we all are, I was very new to this approach. I did not have much idea to where my orientation of cup will be. So I took multiple fluoro shots, and these are the images of the C-arm. So we place the cup and the liner, and then doing this, he was a very lean, thin boy. So this gave me an advantage and courage to do a total hip through a direct anterior approach. So broaching was done, and then trial was done. So I have started trying in other scenarios as well, like neck femur fractures. So this is how the whole setup goes. It is very easy to put the C-arm in AP and keep seeing what you are doing. So this is and later on I went and did the other side as well, because he was so happy with the first one. He recommended it has to be done, it has to be done. So this is what I have done. This side, the cup is not very well placed, but he's doing all his activities. And so this is February 2020, and this is May and September, and this is the October. This is the recent one which I have from him. And this is his clinical photograph. These are the skin incisions, and he's happy and he's doing everything. So some few take-home messages. As we have a choice of having fluoro in the OT, we can very well place the cup. We'll know the version, the opening of the cup, whether it is vertical or horizontal. Bilateral hips can be approached, although I didn't approach both the hips in single sitting. But this technique has a steep learning curve and needs proper instrumentation, as the patient was very lean and thin. So I got away with the normal instrumentation, but for a heavy patient, the instrument has to be there, or else you'll be in trouble. Thank you for patient hearing, and if any question is there, I'll be happy to answer.
Yeah, interesting. I think any questions? The only thing I want to say here, what you emphasized, and this should be, you don't feel apologetic for using a image intensifier. It is there. I know it has got some exposure issue, but we want a good outcome. So never feel apologetic for using a image intensifier. Till date, I do use for many of my hip cases, which are difficult cases, whatever approach I'm using. So that's the only point. The other panelist I would like to ask, Sandeep.
One point, he's a very young guy, 17 years. I would have said he would have chosen the approach which he's well versed with, because I don't think the little cup placement on the left side and the stem placement on the right side could have been much better, because he's very young. He will require revision. Second thing, if the cost constraint was there, or he would have used a ceramic head instead of metal head, because he's very young. He'll be going to use his hip too much. So these are the two. I would like to do in a young patient a surgery which you can do better. You have more experience in that. You have done more cases. In anterior approach, he could have done more fracture cases on, but this requires good placement of implant for longevity. That is the only thing.
I'll be interested to know what was the range of motion of the hips preoperatively.
So preoperatively on the, if I may share my screen once again. So preoperatively on the right side, the one with this one, not much of movement was present, but he was able to flex his hip, but he was unable to squat and sit cross-legged. So fairly good range of motion was there. So it was not fused. So I was able to make the head move inside the acetabulum. So that is how I could dislocate it.
I would be a little worried to use the anterior approach in a stiff hip. Actually, that's
yes, I do understand. Yes, too. But there, he was it was mobile. It was not a fused hip.
Okay. Dr. Arora?
Yeah, just was curious to know, why did you use a collared stem uncemented? We can go ahead with the X-ray. I think it is collared stem on
Yes, it is.
uncemented collared stem. Any particular reason?
No, sir. No particular reason for using, but this was the implant I've been using in a Indian setup. So this is the one which I have.
Anybody in the faculty using collared stem uncemented?
No. I think the Corel collared stem is popular with a few surgeons, and there is some logic in using a collared Corel stem. Personally, I don't use it much, but I've seen it being used. Some people prefer to use it.
No, Dr. Aruna, they have in recent paper about Corel, the 30-year-old survivorship study, which has shown that the collared stems have done a shade better than the uncollared. But still, I don't use collared. I still think the white to get a stress shielding effect there. And Corel, otherwise, a beautiful stem. We all have been using it. So the paper say that. But then, Dr. Swarup, you must be seeing that paper also, because that gives some justification for using a collared stem. Any other question, any query? I think, but Dr. Swarup, yes, you are very young. So what Dr. Sandeep, the point he raised are very, very relevant and pertinent. Just take care, that's all. Because he's very young, we have to do a perfect job. And what Dr. B.D. Chatterjee said in the first lecture, in a difficult case or new where you are a little cautious, so many things are going into your mind, always use the approach which is you are most familiar with. So in a young age, you have to have a very, very good outcome. In a 70-year-old, you may get away with such a stem, but here it might give you trouble after 15 years, maybe. But we don't know. It's all assumptions. So let's hope now the patient is happy. Let's hope everything will be happy. Thank you, doctor. Good. And whatever table you use, the normal table which we use, or you had some other table?
Plain table, sir. Plain table. And
so how you
make the patient
extension, because the hip has to be extended well.
Yes. So when we are going for the extension part, we make the patient shift to the border of the table, and we put the leg down and somebody will just bend down and give a traction and externally rotate it.
Okay. So that's too much of maneuvering although anyway. Chale. So we'll go to the next case, that is by Dr. Parvez Hassan. He's from Bangladesh. So there's again a case of prosthetic hip. And welcome, Dr. Parvez.
Thank you very much. Thank you. Welcome to you all. I am Dr. Parvez Hassan from Bangladesh, working in a private medical college in Dhaka. Can you hear me?
We can hear you. Only your screen is not yet visible.
Screen?
The screen sharing has started, but it is not coming. To show that you are sharing the screen, you have to click on that. You may get out and do it again. That may help. So you share again and click on the share. Okay. Mr. Viraj, can you guide Dr. Parvez?
Can you see me? Can you see my?
I can share.
Dr. Parvesh, Sriram is sharing your presentation. You'll have to save next slide or something like that. That's all. You will forward the slides.
কি স্যার আমাদের
Yes.
Sriram is trying.
Yes, sir, sharing. Is my screen visible?
Not screen, only. We cannot see. Yeah, now we can see the.
আগে তাহলে এটা কি হলো এতক্ষণ বসে আপনাদের একেবারে
Enable editing.
ওকে তাহলে আপনাদের চলো চেঞ্জ করছি তাহলে আপনি এটা দিতে পারলেন আমাদের রিসেন্টটা একটু টাইম নেন আমাদের কাছ থেকে 1 মিনিটের জন্য আমার কথা
Yeah. Is it visible?
একটু টাইম Yes, I'm seeing. Okay. 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 Next slide, please.
Next slide, Sriram. You have to move. He said.
Okay, next slide. You can see a 75-year-old woman who have undergone an operation in the left hip 3 years back, and hemiarthroplasty modular type was operated on her left hip. She presented to us with severe pain on her right hip after a history of fall on the slippery ground. Next slide. Next slide. You can see the previous slide, please. Previous slide. Yes.
Okay.
Okay, this is a pre-operative picture who have undergone operation in her left side 3 years back. She presented to us with a fractured neck of the right femur due to fall on the slippery ground. She is 75 years old lady. This is pre-operative picture. Next slide. We undergone total hip replacement in her right side, that is cemented total hip replacement done. This is post-operative picture. Next. Patient was doing well and walking pain-free. At 27 days post-operatively, she tripped and fall again and landed directly on her right side. At that period, she did not lose her consciousness, but she only complained of pain in her right hip and was not able to ambulate after fall. Next. She was then taken to emergency for further evaluation. Her past history is non-contributory and surgical history has already mentioned previously. Physical examination include pain on her axial loading and there was restricted movement, both internal rotation and external rotation of the right hip. Her skin was intact and her sensation was good to light touch and motor function of L4 to S1 distribution was okay. She do not have any tenderness to palpation around knee or distally. She had 2+ dorsalis pedis and posterior tibial pulses is okay. An AP X-ray of right hip is obtained. Now comes, we had 3 questions. What is the most likely diagnosis? What other aspects must be considered before going for next treatment? And what is the most appropriate treatment for her? This is the X-ray after fall on the right hip. You can see the periprosthetic fracture of a cemented total hip replacement. The most likely diagnosis is periprosthetic fracture of the femur, and we should go for additional consideration. The stability of the prosthetic femoral system and the quality of the remaining bone stock. Appropriate treatment is, of course, it must be considered seriously. So we have to think what we will do. Revision of the femoral component to a cementless porous coated long stem that bypasses the fracture by at least 2 cortical diameters is our plan. But we should also consider the revision of the femoral system to a cement also. And we should also consider the fixation of the fracture by cables, plate screw, and or strut graft. Now comes what we did. This is our operative picture. There was a fracture of the shaft of the femur, you can see, and you can see the cup. This is an operative picture, paraoperative picture. The bony fragment came out and after removal of the bony fragment, because there was a cement, during removal of the cement, this fracture fragment came out. This is after removal of that long pieces of the bony fragment. Then we fix the bony fragment by the plate and wiring. And after fixation of this plate and screw, we then fix the stem. You can see the AP view of the after fixation of the by cable wire. And again, we have introduced the stain by cement. And this is the picture after reduction. This is the post-operative picture of the cemented total hip replacement. We have given the same stem and then applied the plate and screw. You can see post-operative picture. the Vancouver classification. This was the type B2. We have classified the Vancouver classification. Literature review. Berry showed that best result with cementless femoral stem, achieving stability in 77% cases. But her bone stock was not good, and we could not go for cementless, applying the cementless femoral stem. And Residis reported that cemented stem with impaction of bone grafting for B2, B3 femoral fracture can achieve good. Everyone knows the complication, the aseptic loosening, fracture non-union, deep infection, pain from cables, wires, dislocation, and sciatic nerve injury. We had a follow-up of this patient about 1 year. The patient is now good. She can walk on support, and now patient is okay. Because patient cannot go out of his home, we cannot give her recent picture, but patient is well now.
Okay, Shriram, you can stop sharing. Okay. Questions? Can we start with the young people? Dr. Amit Verma, your take. What you would have done differently?
Amit, your mic is muted.
Bypass the fracture by using a longer stem, I suppose.
Yes, thank you for your question. We had offered the patient for longer stem. The patient was really poor. In our context, in our country, a patient cannot bear the 2 operations within very short period. But it was become acute emergency situation. A patient had a lot of pain, and we give the same implant. We know this is our drawback of the operative side. If we had offered the patient, but patient cannot afford that. But if any other patient, we definitely, it will be good for using the longer stem, definitely.
So after all this construct, how long did you not allow weight bearing to the patient? For how long was?
Yes, thank you. No, as the patient came just 27 days after first operation, she go for a second, accident. That's why I advised her not to bear weight about for 1.5 months.
Right. Any other questions, Dr. Arora?
No, I think it was the financial constraints are always there. Undoubtedly, we have all worked in the government setup. But for the message of delegates, for our younger friends who are going to venture, I think the message is clear. The stem has to be long, uncemented preferably. If you are going to cement, put a longer stem, bypass the fracture. Because if you are fixing with a plate and the same stem, the load is going to come on those unicortical screws and cables. So God has been kind, the fracture might have united, but the message should go across for a longer stem.
So
we understand the financial constraint, we know that.
Using a cemented stem, it is better to have some impaction bone grafting also. Otherwise, all the cement will go and leak into the fracture site and it may never unite.
So that was a prudent way of not allowing the weight bearing, because now with this constraint, Dr. Parvez, I think, yes, you did right, because then you have to wait till the bone starts healing. before that, don't allow the person to walk. So that's a very prudent step with the constraint to operate it. The only thing, one add I can say, you could have used a longer plate then. If you're using the smaller stem, if the plate was going till the greater trochanter and holding it there also, that would have given you better support to the cement and small stem construct. That's the only point I think I'll add. But yes, if you have done it totally with a revision with such a stem, then you should try to wait till the fracture unite, then only you start weight bearing. Thank you, Dr. Parvez, for joining us here, and hope you'll be joining more and more with us later on.
Thank you, Dr. Amar Prasad. Thank you, all the faculties, for giving the opportunity to present the case. Thank you.
The next, it's a hip case by Dr. Ravindra Ragmi, and he's from Kathmandu, Nepal. And again, he has an interesting case. And Dr. Ravindra, you can share your screen now.
Yes, sir. Sir, is it visible, sir? My screen, is it visible?
It is visible.
Thank you, sir. Good afternoon, everyone. Warm greetings from Nepal. Today, I am going to discuss with you a complex case of hip, which I came across my career. So this is a case of 40 years old lady who underwent uncemented metal on poly total hip replacement of left side 10 years back. She underwent this surgery for avascular necrosis of femoral head with secondary osteoarthritis following neck of femur fracture. So this was our immediate post-operative X-ray taken 10 years back, which showed no subsidence of femoral implant and well-fitted acetabular implant with screws. And this was an X-ray taken 6 years follow-up, that is 4 years back from today, which showed again no subsidence of a femoral implant, well-fitted acetabular implant, and no osteolysis around femoral and acetabular implant. But 7 years post-replacement, she presented to us with a complaint of pain on her left thigh and groin for last 6 months, which was severe during sitting and rather than walking. So there was no history of trauma, fever, and night cries. The pain was disturbing her daily activities. And then on further history taking, she denied having history of any infection within her and her family member like tuberculosis. And on examination, she was limping on the same side while walking, and on a local examination, her overlying skin condition was normal, and there was minimal tenderness over the greater trochanteric region of the same side. The range of motion was not painful and was within normal limit. So I sent for the investigation. The blood investigation was sent, which showed her increase in CRP and ESR, and other blood investigation was within normal limit. And the X-ray of the left hip was sent on the same time, which showed periprosthetic lucency over acetabular zone 1 and 2, and then femoral zone 1. And there was a proximal femoral lateral cortical erosion was there. There was no migration of acetabular and femoral component as compared to the previous one, and there was a patchy osteolysis in the acetabulum and proximal femur. So ultrasound of her left hip was sent, which showed no soft tissue collection and no collection in the hip joint. The bony lesion could not be well appreciated. And since there was no collection, there was fluid from the hip joint. Hence, I think of sending a CT scan. So CT scan was sent, which showed periprosthetic lucency over acetabular zone 1 and 2 and femoral zone 1. And then there was a medial acetabular defect. So thinking of all these, I was worried whether this is a septic or an aseptic loosening. Then I sent for a bony scan. The bony scan showed foci of increased tensor uptake in the left acetabulum and greater trochanter of left femur in delayed phase, which is consistent with aseptic loosening. So after this bony scan report came, I was confused whether this is aseptic or septic loosening. Hence, to rule out other infection, I have sent the blood culture and then urine PCR for tuberculosis, Montu test, AFB for TB, chest X-rays, and again the ultrasound, which all showed the negative investigations. So after all this investigation, my provisional diagnosis for this case would be aseptic loosening or septic loosening. But the point in favor for aseptic loosening is only a bony scan, but the other point are in favor of septic loosening. So after that, I planned for a revision surgery, whether it would be a single stage or a double stage. So single stage or a double stage surgery was planned. So I was prepared for both. So operatively, the femoral component was well fitted, and I need to do an extended trochanteric osteotomy to remove the femoral component, except there was a necrotic tissue and pus-like fluid in the proximal femur. The acetabular component was loose enough to remove, and there was a defect in the middle acetabular wall, and again there was some pus-like fluid in the acetabular cavities. So preoperatively, only CRP and ASR was raised, which make it inconclusive according to the Musculoskeletal Infection Society criteria. But poroperatively, there was a purulent fluid, and it is more conclusive toward the infection. Hence, after this Musculoskeletal Society Infection Society criteria, we thought of infection in this case, and we planned for a double stage surgery. Mycobacterium tuberculosis, and again the biopsy of the necrotic tissues from the femoral and acetabular side shows areas of caseous necrosis and area of granuloma composed of epithelial cells and lymphocytes suggestive of tuberculosis. So finally, we make a diagnosis of tubercular periprosthetic joint infection in this case, and the patient was started with anti-tubercular therapy. Now the challenge for us is to go for a final procedure. So for a final procedure for femoral side, we need a long stem, since we have done a extended trochanteric osteotomy, and then since the patient is young and there is a good bone quality, we need to go for the uncemented one. There was a middle bone defect on the acetabular side, and then there was a bony defect in the acetabular superior and anterior wall. So for that, we need a bone, but unfortunately, bone bank is not available in Nepal. So what we thought was, for the bone graft, we were planning to use the iliac bone graft to fill the cavity, and to again the iliac bone to fill the medial wall defect. For the prosthesis for acetabular size, since there was a cavity, the rim of the acetabulum was intact except the medial cavity was just perforated. We're thinking of putting a bone graft from the iliac wing side, and then use a large acetabular cup for the prosthesis and acetabular side. For the femoral side, we need a long uncemented stem, but we are unable to order it from India because of some custom issues. So finally, what we thought was, we ordered. So finally, what we did was, we have a Johnson & Johnson 12 size stem with us, which was approximately 4 centimeters longer than the osteotomy side, and which will be well fitted in the metaphyseal region. So with the final solution for us will be the uncemented 12 size femoral stem from J&J. So further, we plan for the second stage revision surgery for using the primary implants. So what we did was, this is a poroperative picture showing osteotomy prosthesis with bone cement on it. So we removed the osteotomy prosthesis and bone cement from there. There's a cavity in the superior and anterior wall of acetabulum, and also in the middle bony wall defect was there. So we filled that cavity with the iliac wing bone graft on the medial side, and then the cancellous bone graft was used to fill the anterior and superior acetabular wall cavity. The uncemented acetabular cup was used, and it was well fitted in the acetabulum with 2 screws. And on the femoral side, uncemented stem was used as well, and there was an anterior wall defect on the proximal femur, which was well covered with bone graft and was fixed with the SS wire. So this is a poroperative C-arm pictures where you can see a bit longer stem. So this is a post-operative X-ray where we can see well-fit acetabular implants with 2 screws and well-fit femoral implants, and then extended trochanteric osteotomy site was well fixed with the SS wires. So post-operatively, patient was asked for weight-bearing mobilization with crutches for 6 weeks. The patient was out of bed after first post-operative day. Indomethacin was started post-operatively and was continued for 6 weeks. This is a 3 months post-operative X-ray where you can see no migration of the acetabular component, well-fitted screws, and healing extended osteotomy site, and there's no subsidence of the femoral implants. So on follow-up, patient becomes symptom-free after second stage revision surgery. Anti-tubercular therapy was continued for 18 months. X-ray and CT scan revealed healed acetabular and femoral defects. So this is a 1.5 years follow-up X-ray where we can see the healed acetabular defect and femoral defect with well-healed ETO site in the femur, and then no migration of the acetabular and femoral implants. This is a 1.5 years post-op CT scan. Again, we can see the healed acetabular defect on the medial side and superior and anterior side as well. So this is a 2.5 years follow-up X-ray of the patient with no lucency on the acetabular and femoral side, with no migration of acetabulum and femoral component. The defects were well healed and then already healed extended trochanteric osteotomy side. So this is a rare case. This case is a rare complication as there is no previous history of pulmonary or extrapulmonary tuberculosis in the patient, and there are only 41 cases reported in the literature so far. I found it, and among all tuberculosis cases, the incidence of extrapulmonary tuberculosis is just 20%, and among extrapulmonary cases, the incidence of bone and joint infection is just 10%. So hip joint is the most common joint be affected by tuberculosis, and then primary tubercular osteoarthritis is well known, whereas periprosthetic tubercular infection are very uncommon. So take home message from my side after this case is, in spite of having low incidence of periprosthetic tubercular infection, tuberculosis is very common in our part of the world. Hence, it should be ruled out in any periprosthetic joint infection. Thank you very much, sir.
Thank you, Dr. It's a very well worked up case. So it's open to discussion, and just I will say that the TB is not uncommon. We all know. I had 4 cases where we did ATT, gave ATT later on. All the 4 cases, the only 2 had a positive biopsy in favor of tuberculosis. The other 2 were in favor of chronic infection. But there was some evidence which suggested that it can be a cause. But the other 2 which didn't have a positive case had a history of pulmonary TB which was treated. So anyway, this is something which can happen. We all know. So can we start with Dr. Jha?
Yes. Well, you have rightly said that giving anti-tubercular treatment is so very important. So would you like to wait for a month minimum before instituting anti-tubercular treatment? So any lag?
So thank you for the question, sir. So for this case, since once the biopsy came, I started the anti-tubercular therapy. I have not waited for that. So before biopsy report came, I have not started the anti-tubercular therapy. Because of lack of any evidence, I could not start the ATT. That's what I think. So I didn't start anti-tubercular therapy in this case before biopsy and PCR report came out to be positive.
That's good. Dr. Arora, yeah, any comments?
Quite an interesting case, and I'm quite amazed with all these constraints, how they are able to manage and have courage to do this surgery. Really courageous, believe me.
Thank you very much, sir.
I have only one thing going on in my mind, because we do not have preoperative X-ray. Having worked a lot on osteoarticular tuberculosis, we know it can remain suppressed for decades. Now, pre-op X-ray, unfortunately, we do not have. Was it really avian or something else?
Preoperative X-ray was missing, sir, actually, from the patient.
I know the limitations. I know the limitations. And again, same thing for the message of our younger delegates. We need a longer stem, and congratulations, you got away with all this, and you had the courage to do all this beautifully.
Thank you very much, sir.
You grafted it well, and we can see the post-op CT at 1.5 years. It is well taken up bone graft. So you did a very good job with limited constraints.
Thank you very much, sir. Thank you.
And I think Dr. Jha was asking to do second implantation and wait for at least 1 month of ATT. I think that was the question he was trying to ask.
Okay, sir. Sorry, I couldn't get the question.
Yeah, I think that was he was trying to. Am I right, Dr. Jha? I think he was trying to ask you that when you do an implantation, it's better to wait for at least 1 month of ATT so that, your internal milieu improves.
Okay. So for me, sir, this should be a learning for me. So in this case, I've continued ATT even after second surgery. So that's what I've done. So if I encounter something in future, again, I will wait for another 1 month after second surgery and then continue it. So that will be a learning opportunity.
1 month, then surgery, and then 18 months you can. And the best part in tuberculosis is if you give ATT, the granulation tissue can get ossified. You get good newborn formation. That's the beautiful part.
Yes. Thank you, sir.
It heals beautifully. It looks grotesque when it is eroding the bones, but surprisingly and thankfully, it heals also very well.
Can I make a comment?
Yeah.
I think it is within the constraints, it's a wonderfully managed case. And of course, I fully corroborate Dr. Professor Arora's thing that ideally, of course, a long stem should have been used. But I think it's a rarity to get a a periprosthetic infection with tuberculosis, mainly because the tubercle bacillus is an intra-articular pathogen and it is not known to form biofilms. So in that respect, I think the chances of reinfection is low because it does not form a biofilm. Primary tuberculosis is, of course, a different matter. And here, Professor Shanmugasundaram has done a lot of work. And, I've published in tuberculosis in THR in primary tuberculosis. And what I can say is that AKT makes a phenomenal difference in the operative field. When you open a primary tuberculosis of the hip, it is full of granulation tissue. The bone is soft. If you just press with a finger, you can indent the bone. And it's almost impossible to put an implant in there. But 6 weeks of AKT and it's completely transformed. The granulation tissue is gone. The bone is much firmer, and you can even sometimes put in a non-cemented implant. You actually fix a non-cemented implant. Of course, a lot of the time you may need to go cemented because of the osteolysis and osteoporosis. But periprosthetic infection with tuberculosis, well, I think it's a rarity case which I think should be reported. And because, like I said, it's an intra-articular pathogen. Interesting also, whatever papers have been published in such situations, most of the pathogens isolated have been atypical mycobacteria. So there is a higher incidence of periprosthetic infections by organisms such as rapid growers and other atypical mycobacteria rather than Mycobacterium tuberculosis. So I would like to ask Dr. Rabindra that was it Mycobacterium tuberculosis or was it some other atypical pathogen like photochromogen, scotochromogen, or rapid grower?
So it was Mycobacterium tuberculosis because PCR, fluid PCR for Mycobacterium tuberculosis came out to be positive, sir.
No, did you culture the bacteria with BACTEC or did you use tubercular culture medium?
We have used yes, sir.
Loeffler serum slope or something to actually grow the bacteria?
Yeah, we have sent for Lowenstein-Jensen medium culture, sir.
Yeah, LJ medium, yeah. Did you grow it on LJ medium?
The bacteria could not be grown in LJ medium, sir. Growth medium came out to be negative, but PCR came out to be positive, and then the biopsy report came out to be positive. Both of the report made us think that this is a tuberculosis case, but this growth was not there, sir.
Yeah, so that's what I'm saying. Is the PCR specific for Mycobacterium and atypical Mycobacteria?
Yes, sir. It's specific for Mycobacterium tuberculosis.
Okay.
Can I ask one question?
Yeah.
Just curious to know, because it occurred 10 years later. Did your host got immune compromised, like HIV status or uncontrolled diabetes? Anything predisposing for late infection 10 years later?
No, sir. She was absolutely fine. She didn't have any history of diabetes or HIV and all those. She's just 40 years old female. She had this surgery at the age of 30 years, primary surgery at the age of 30 years. So she was from quite low socioeconomic status. Her husband has renal problem and had undergone renal transplant surgery, and then all those problems are there. She was on antidepressant medicine, but not an immunosuppressive medicine, sir.
Yeah, in our country, even malnutrition is one which can cause immune compromised status. Dr. Sandeep has a question, I think.
Yeah, I just want to know what antibiotic you have used in the spacer.
So it was gentamicin, and then we mixed vancomycin in it, and then.
Yeah, that's a good choice. Basically, what wanted to tell the other delegates and all, whenever there is infection, whenever you are suspecting osteolysis and the CRP is not very high, to think of mycobacterial atypical also is very common, and tuberculosis could be there. So if you use aminoglycoside in the spacer, it is going to help, especially amikacin, because atypical mycobacterium, the non-ATT is not helpful. Amikacin is the one which you can use with vancomycin for all the spacers. And we have customized molds also available. Customized molds, instead of using Austin Moore, you can use molds are available for hip spacers. And if you're using like for Patricio or something like in this case, is a young patient, whenever there is a defect, is there, try to use a multi-hole cup and try to get purchase on all the 3 columns. rather than just a superior column. Sometimes if the bone quality is not good, it will back out and become more vertical.
Okay, sure, sir. Thank you for suggestion, sir.
Okay, thank you, Dr. Ravindra. It was a really good, yes, very good.
Thank you, sir.
Can I call, actually, Dr. Anup Agrawal is a little held up. He has to attend a different meeting in KG Medical College. He's from Lucknow and is again one of the core group members. So can I call Dr. Tanveer Hassan Siddiq from Bangladesh? Dr. Siddiq, can you share a screen?
Yes, sir. Good afternoon, sir. Am I audible, sir?
Yeah, perfect.
Can you see the screen?
Yeah, we can see, yes.
Good afternoon, sir. I must apologize at first, as this is rather a short study, not a case discussion. The title of my presentation is Long Stem Femoral Component for Complex Hip Arthroplasty, a study on 8 cases. This is my working place. It is a government hospital in different views. Well, we know total hip arthroplasty is the only viable option to provide a painless and mobile life for the management of advanced osteoarthritis, primary, complex primary, and revision. Based on the implant types, it may be cemented, non-cemented, hybrid. The pros and cons are long-stem revision femoral components prevent periprosthetic fractures by bypassing the weak areas of the cortex. And it can be used in the bone loss in the following proximal and middle third of the femur. And the disadvantages are the femoral anteversion maintenance may be a challenge, and risk of distal femoral cortical perforation remains. This small study was carried out from the period of March 2019 to February 2021, that means 2 years, on 8 cases, small sample size. The mean age was 62.6 years to 6 years, ranging from 29 to 92 years, where 6 were males, 2 were females, 2 were revisions, and 6 were complex primary. All the cases were operated through lateral modified Hardinge approach. Here is some cases. The first case, a 55-year-old male who had cemented total hip replacement by channel prosthesis elsewhere in 2010 for avascular necrosis of the left hip. And after 8 years, with severe left groin pain and inability to walk, came to us, and this was his X-ray. And after just doing all relevant investigations to search for the cause, whether it is aseptic or septic loosening was diagnosed, and we proceeded for revision through lateral approach. This was this picture. This is the previous operative scar, and we planned lateral approach. And this is after removal of the acetabular component and after removal of the full channel prosthesis. And this is the immediate postoperative X-ray. And this is the X-ray after 8 months. And the patient came to us using the public transport individually. This is the next case, a 29-year-old male. He had a fractured neck of femur in 2016 in abroad, where he was operated in the form of closed reduction and internal fixation by cannulated hip screw, but that ended up with non-union. In 2018, in Bangladesh, he was operated elsewhere, where the implants were removed and uncemented bipolar hemiarthroplasty was done. But after 3 months following the second surgery, he noticed pain and limping and weakness. Gradually, his condition deteriorated. And After relevant investigations, stem loosening and subsidence were found, and we planned for revision, and we did cemented total hip replacement using long stem femoral prosthesis, again through the lateral approach. And this is the final picture after reduction of the components, and this is the post-op X-ray. And the patient, we did it in June 2019, and this is the last follow-up after 7 months, 6 months. And the patient is now still doing good. Another case, a 92-year-old male suffering from Alzheimer's disease had a fractured neck femur with trochanter fracture with subtrochanter extension on right side. And he was treated initially elsewhere by surface traction conservative treatment for 3 weeks. Then, as the party could not just control him, just brought to us, and we planned a total hip replacement by cemented prosthesis using long stem femoral component with wearing of the subtrochanteric fracture. This is the picture, and this is immediate postoperative X-ray, and the 6 or 7 months, and still the patient is alive and doing good and can walk independently. And this is another case. A 80-year-old female had intertrochanteric fracture, and for which closed reduction and internal fixation by cannulated hip screw, dynamic hip screw was done in 2018, but implant failure occurred. See, the leg screw was cut out, and for non-union, the implant was removed elsewhere. And afterwards, she came to us, and we planned for total hip replacement using long stem cemented femoral component. And this is the picture after reduction of the component. And we did it in April 2019, and this was immediate postoperative X-ray. The patient has been doing fine, but unfortunately, in December 2020, she expired, being a COVID victim. So, all rest 7 patients are alive, and outcome was evaluated using modified Harris-Hip score. One had superficial postoperative infection, possibly a suture sinus, which healed after removal of the suture end within 3 weeks with proper antibiotics. One had mild pain on walking for 9 to 10 months. 4 had mild limping. 1 uses a cane on walking. 5 can use stairs independently. 1 can use stairs with a railing, 1 with help. 4 can use public transport independently, and 2 had still with active abduction. So, long stem cemented femoral component is an effective option for complex total hip arthroplasty, including revision, especially in proximal femoral bone loss or a risk of periprosthetic fracture. But the important issues for actual outcome are proper patient selection, pre-operative planning, medical surgery, post-operative care, physiotherapy, rehabilitation, and last but not the least, the regular clinical radiological follow-ups. Thank you for patient hearing and allowing me. Thank you, sir.
Thank you, Jok Saab. Love, interesting collection. So, any queries you would like to have from Dr. Siddiqui?
You have used, Dr. Siddiqui, you have used long femoral stem for various indications. But in terms of results, some of your patients, or maybe I say 50% of your patients, are still not independently walking. They are either using aids or some support. So, what is the lesson that you have learned? How can you improve your results?
Sir, thank you, sir, for your questions. Sir, actually, in our country, as my previous speaker, Dr. Parvez Hassan said, that we have some constraints of implant choices, and also there are some economic issues. But what I should learn, there are another constraint, and that is the physiotherapy and rehabilitation postoperatively, and it should be improved. And after doing surgery, in this sort of cases, we are worried about infection. But after the patient discharged with advice, most of the patients are just aware about the rehabilitation techniques. And that's why during follow-ups, some patients used to come regularly, some are missed, some are just coming irregularly, not maintaining the rehabilitation program properly.
Right, thank you. Dr. Anil, you want to make some comments?
Yeah, so if we keep our financial constraint aside, I understand, totally no, because working in those areas, you have a big financial constraint. But in ideal setup, again, for the messages of our younger friends, in revision scenario, the preferred stem is uncemented because the endostem is quite smooth. There is no cancellous bone left for interdigitation of semen. And if there are no financial constraint and patient can afford, and you have an access to all the kind of stems, it is preferable to use a long stem, which is uncemented for longevity of implant. Now, if you are forced to do a cemented stem, then one needs to learn the art of impaction bone grafting. Again, you need bone bank for impaction bone grafting. I'm talking of ideal scenario. I'm not talking of constraints because we all understand those constraints. That's the only comment I want to make for our younger friends who are attending this meeting.
Yeah, that's true perfectly. Long stem cement is a salvage situation. So we all know that. But we all have gone through the same constraints and worked like that. And
undoubtedly.
One of my comments regarding the bipolar, it could have used a normal conventional short stem. There was no breach in the cortex anywhere. It was just loose.
Yes, sir. Could have used, but
short stem could have been used.
Yes, sir, you're right. But as in the second case, that case, as we operatively, it seemed that the bone quality was softer, and I was in a fear that there might be just something. We had options. We had just short stems with us, but we still preferred a long stem. And one thing, just worthy to inform you that, unfortunately, uncemented long stem femoral component is not available in Bangladesh.
I have a question. Were you cementing the whole length of the stem, or were you cementing only the top part of the stem?
Thank you, sir. We used cement gun in all cases, and we tried to just, after putting the cement restrictor, we tried to just insert cement as long as possible. But our main aim was to just reconstruct the proximal portion.
No, because I mean,
that was visible.
Hello, can you?
Yeah, we can hear you.
Yeah, no, because you see, the problem of putting a cement restrictor in this is, you see, the stem goes right down, so the medullary canal keeps widening. So it's very difficult to actually fix a cement restrictor in these cases. So that's some of the difficulties which I face. So I don't know whether it's at all possible. Otherwise, you will need a huge quantity of cement to fill up the whole of the medullary canal. So were you doing that,
yes,
or you were just cementing the top part and letting the rest of it just remain?
Yes, sir. We just tried to just insert cement whole length, and we needed cement more. That means at least 2 units.
Good, but anyway, interesting cases, and we all face such cases day in, day out here also. So it was good, Dr. Tanveer Hassanji, and it's good that you joined from Bangladesh. And Dr. BG Chatterjee is there only in Calcutta, so we can always form a good association. BG, Buddhadev, you can. I think you are going to Bangladesh often now.
Yeah, no, last because of the pandemic, I have not gone, but I have been attending their BoaCon, and since we share the same language, so it is always a pleasure going to Bangladesh. My mother-in-law is from Bangladesh anyway, so.
So we had same, because I was brought up that part. I'm stuck up in Kanpur, but my first name is still Amol. So
Amol. No, but you have to change it to AMOL actually.
yeah, no, that becomes Amol. It's not Amol, it's Amol. It's AML, but pronounced, that's what my auntie was pronouncing. She gave me that name. She was from Bengal. So anyway.
It's a very, very common Bengali name.
Yeah, so that's why it was given. My name was given by my chachi, and she was from Bengal. So that's why. Anyway, that's beside. We'll come to the last case, and in fact, Dr. Anup Agrawal may be joining for discussion, but his video presentation is there. So, can you present his Anup's video case?
Dr. Amal, can I take your leave?
Okay, Dr. Anil, thanks for giving
It's an honor.
me the
I have
time.
to come there at 2 o'clock. It has always been an honor to be a part of this course. Very informative, and congratulations to all organizers, Professor Amal, for this great show. It has become truly international.
Thanks, Dr. Anil, and you are always with us. That's the best thing.
I
You
enjoy
always-
being in your company.
Thank you. Okay, it's I think mutual then.
Thank you. Bye-bye.
Okay, bye Anil. Bye from all of us. Thank you.
Yeah, I'm sharing. Yeah, sharing.
A case of 70-year-old female, type 2 diabetes mellitus, had an hypertension, had a right THR done in 2016 for her fractured neck of the femur. She was doing absolutely fine, walking, everything was done, and suddenly
Is it visible? Hello?
We are not seeing. The slide got stuck, friends. Friends, Dr. Jha will be announcing the awards also for the best cases.
Suddenly she had a trivial twist, that's what she claims, at home, and she fell on January 21.
Hello?
So she came to me with this x-ray, though I have a previous x-ray where it was done the THR. The stem was protruded like this in that post-op x-ray also. So here you can see it is broken from the neck, stem is protruded, is well cemented stem, well cemented cup. So question comes, what and how? Looks like simple, that remove this stem, and you can plan either a cemented long stem or an uncemented stem. Probably cup is well okay. So
Next slide.
we may not require it. So we planned it. We opened through the posterior approach, removed the broken head. Removing the stem wasn't very difficult. It came out really very easy. And then we started removing the cement slowly. We all know that's the most difficult part. And we were removing the stem, and with a small reamer we were trying to prepare it for the stem and remove the stem, and suddenly a click wise and we had it. So we saw it in Siam. There was a long spiral fracture extending from beyond the cement plug till the proximal part of the GT. It was a long spiral fracture. So we decided to remove the cement plug and rest of the cement debris through this fracture side and then passed a guide wire. Did a close reduction, clamped it well, and then did multiple encirclage wiring. This is how we did. We kept these encirclage wiring loose. We started reaming with that. We did a trial stem. Once we found that everything is over, we did a final stem. This is how it looks, and then we tied up the wire also. So per op, it was all stable. This is the per op picture. I had to open it, though I had a collinear clamp. I did try with that, but it wasn't very satisfactory. So because of the spiral nature of the fracture, so I had opened it completely, and then we did an open encirclage and reduction. This is the final picture, but there is a large long butt on this. Patient was doing well. The stitches removed. 4th week, 3rd to 4th intervening week, she started having pain on the right hip. There was swelling over the lateral aspect of thigh, and on examination there was induration at the trochanteric region. So I decided to aspirate. The fluid wasn't exactly purulent nor serous. It was whitish red fluid. Sent it for the culture sensitivity, got the blood investigation done, CRP, ESR, all was raised, poly was also raised. We did the synovial fluid aspiration also, sent it for culture, culture was negative, WC count was well below 3000. So I decided that probably it's not the complete picture of a joint infection, but probably it's a localized area of infection in the region of trochanter and all that. So we discussed it with the patient attendant, and we decided to open it. So
श्रीराम आप थोड़ा तेज चलाइए.
Went through the posterior approach. Well, this was the post-op X-ray. This was the X-ray in March. We did it in January. Then this is the X-ray in June 2021. So we started in June. We started. She started doing weight bearing also. She was doing all well. And then she came with this. She again had a fracture. So this was the distal fracture. This is the post-op 1.5 month X-ray. This is the most recent in September X-ray, and this is the X-ray 3 months. This is rather the most recent X-ray. What did I actually learn from this case, or what is the message which I wanted? The tip number 1 is that whenever you are reaming, always put a clamp, preventive clamp or preventive encirclage wire. Tip number 2, whenever you are reaming, especially in a short lady, you have to be careful about the curvature. So always look at the C-arm, where are you hitting? And if you're hitting like this, avoid doing it with the rigid reamer, have a flexible reamer and do it with the flexible reaming. The tip number 3, your assistant is always curious to give you. Tip number 4, the stem. The final tip is that you should always keep each and every message. So thank you.
Interesting. Stop sharing. It's an interesting case which Dr. Anup showed. I do not know whether he could join or not. Dr. Anup has joined? No. Okay, so this was the case. I think he and Dr. Anup summarized anyway what are the things. And the most relevant point for a long stem is that we must know our femoras are curved. And more so in our Asian subcontinent, it is more curved, especially in female. It is. So using a straight reamer can be very, very dangerous. All hip surgeons have burned their fingers if they try to get a shortcut. So if at all needed, see the length, and that's why I always say, in such cases, there's no harm in using an image intensifier to check and cross-check. Yes, exposure issues are there, but please don't shy away from using an image intensifier. And we all are, our operation theaters always does trauma surgery as well. So the machine is always there. Why not use that? So that's one tip I would like to say. And then when I say joint replacement doesn't have shortcuts, we all have been trained well. We know what is right. Be prepared for all the armamentarium, primary, even a primary knee, primary hip. Whatever you do, there should be backup plan. You should know what things can go wrong, and you should be prepared for that. In a primary knee also, I have got constraint inserts there. So something like that. It needs little effort, but there's no harm. And if you think that nobody buys those instruments, you have to ask your supplier, the provider, to keep the backup. Otherwise, you don't use his instrument. That's very clear. So, because the brunt falls on the surgeon, not on the instrument supplier. So, learn to dictate what you want. That's all. But the rest, I think we all have got very eminent faculty. Sandeep, you also do a lot of things.
Sir, I just want to add, I have very low threshold for doing an eccentric trochanteric osteotomy, removing all this cement. So it makes life easy. You remove cement in 5 minutes, and then your endosteal preparation is very easy. You are not going to touch the anterior cortex. So 2 ways it is helpful. Like in this case also, stem was touching the anterior anterolateral cortex. So that is why the fracture happened. And he could not bypass that fracture also. So a small trochanteric osteotomy would have made the job very easy.
Now, I have a suggestion. I think I would have seriously considered doing cement in cement technique here. It would have simplified matters like anything. And he said that the stem came out very easily, which happens in a polished cemented stem. So all you need to do is a cement in cement, and then you don't have to go through this whole rigmarole.
Maybe the design of the cement, the design of the stem was some Indian design. So it was not polished taper design. Otherwise, cement in stem would have been best choice.
No, you can use something like a CPT stem. You see, which
zero
is
size
CPT, which is very narrow. It goes in most places. So I think that would have simplified the thing enormously.
And that's it. I still agree with Dr. Buddhadev Chatterjee. The cement in cement, which when it came, we started trying it. Yes, the selection of the stem is vital because you don't want to break the cement mantle. But yes, you can try to ream it little one. So you can get the same. Try to get a narrow one, and it works very well. Or otherwise, the ETO is a surgery which every hip surgeon must know. I absolutely agree with Dr. Sandeep. We all must know how to do it with flair. And there are a couple of things you can extend, how much you go, but doing it and closing it, everyone must know. Dr. Jha, your comments?
Yes, you have been correct that avoiding is the best part of your performance. So if you can foresee that going into details of removal of the cement, it may lead to complications, why not prevent it? And for that, cement in cement is a good option.
That's right. So we come to the end of this session. Can we have everyone of the group on the screen now?
Dr. Rajesh Malhotra, is he still here?
Yes, sir. I'm very much here.
Wow.
Yes.
Rajesh, boss, that's great. Dr. Jha could know it. Good.
Yes, he was present yesterday also.
Yeah, yesterday I said hello to him.
Okay.
For hip cases, Dr. Rajesh would have been a great help to give comments.
I just kept to the agenda given to me. That's why I didn't say anything yesterday. I was just absorbing knowledge.
Wow. That's a good comment and maybe lesson for many.
I don't like to be an uninvited guest, but I like to attend.
Not uninvited. You are part of the family. We all know it. Just so well now.
Thank you so much. Thank you. Really appreciate that.
So, Viraj, can we get all the people who are there on the platform so we can just wind up things? And thanks, Dr. Rajesh. Your surgery was fabulous. I'm so tempted, but maybe first I'll come and assist you.
You're most welcome anytime. Anytime.
And then I'll definitely, without assisting you, I'll never start anything like that.
But we have a cadaver course on 29. So many of those who, those who are early in their career, who are not experienced arthroplasty surgeons, can actually come and try their hands cadaver. I think that way our common thread, DPU Synthes, have been very kind to sponsor that the cadaver course. They are going to provide with all the instruments. So I think that also itself is a great opportunity to sort of try something with your own hands. That is actually also a great opportunity.
That's true. That's true. So I will start with final comments, but first, Rajesh Malhotra, please, sir.
Thank you so much. I appreciate your invitation to participate in this great course, and it was really of a very high standard. The discussions were very good. The cases presented were very nice. The faculty was scintillating. So I think my final comment is congratulations, Dr. Prasad. You have done it yet again. A great feat. Thank you so much.
Thank you. Thank you.
Great job.
So, anyone else wants to say something before Dr. Jha starts with his summary?
Just like to just second exactly what Professor Malhotra said. Congratulations for a truly wonderful course, and thank you very much for the invitation. I think it was a great privilege and honor to be here. Thank you.
You always, not the first time. So,
so wonderfully done. Yeah.
So next time,
wonderful course, Dr. Prasad. Thanks for inviting us all. And
thank you, Mrinal. But you have got really, you will be the future later on. You are still young, so maybe after 10 years, we'll see what else you are doing. That was a wonderfully done surgery you showed. With all the constraints, that was, I'm very happy with. That was a very tough case, almost a floating pelvis, and you could fix it up with bone. The impaction grafting worked very well. So, Sandeep, any comments?
Sir, well organized conference, and the standard was so high that more and more people will be going for online conference conducted like this.
Yeah, I know. I love.
Live surgeries, you have all the panel discussion, high case discussions, and everything. Real life surgeries. So congratulations to all the team and to you, sir. Thanks for inviting.
And Sandeep, actually, I think we all know each other so well now. Anyway, Viraj, can we have other people who are there on the room on single platform, all this platform? All of you all are here. Okay. So fine. We all organizers are there. Dr. Amit, Dr. Vishal, Dr. Vinay Gupta is there. So Vinay, so you start the end proceeding. You invite Dr. Jha now. Mute, you'll have to unmute yourself first.
Hello. Now I invite Dr. Jha for their closing remarks and closing remarks.
Thank you, Dr. Binay. Well, as is customary in any arthroplasty course, hip comes after the knee course. But I must admit that today, even after the last evening session, prolonging up to late evening, today's enthusiasm was worth watchable. And the tempo was from the initial moments when Dr. Rajesh Malhotra came out with his real-life surgery explaining all these steps. Friends, I would like to use one word. I would not say reinventing. I would say repositioning. So this direct anterior approach has definitely been repositioned for use for hip arthroplasty. And definitely it has so many advantages. Dr. Chatterjee was just mentioning that during his PG days and also during my earlier orthopedic training days, tuberculosis used to be so common, and sometimes for even diagnosis of arthritis in a hip joint, a biopsy will have to be taken. And this used to be the approach, anterolateral approach, which used to be practiced. So in a way, persons of our generation have been familiar with this approach, which unfortunately has not been practiced so much by the youngsters. Dr. Malhotra also made it look so simple, which it is not. And he also said that if I only saw the video, things will look very simple. And that is the class of the master, that when the master performs, one who is watching it feels that he can do it without any hitch, but he has cautioned, you have to look into all the details. And what I like most, that apart from detailing all the instruments that he uses, he again said that even with your instrumentation, you can still perform it. And see, one instrument, COPS, which invariably is not used by everybody, has been shown to be used for different purposes, and the dissection became so easy. And he also said that removal of the head can also be facilitated by putting the COPS inside the acetabulum. Well, suturing of the capsule or not suturing of the capsule was a matter of discussion, though Dr. Malhotra feels the joint is so stable that it does not require to be sutured. there were opinions in the house that suturing of the capsule will enhance unless it is really fibrotic or contracted, or there has been a hip flexion deformity from beforehand. Well, immediately after, Dr. B.D. Chatterjee rightly played into various approaches for the hip, and he showed that the majority still today is for posterior approach. Well, in lighter vein, I would like to say that when there is a blast, a lot of people will like to flee from one gate, which may not be very safe. So you can also look for other gates of exit. And here, this anterior or even anterolateral, those who are not accustomed to it, is definitely an additional opportunity to approach the hip. And Dr. Chatterjee rightly said that you can be master of one, but you should be equally efficiently trained in another approach. So it was rightly said. Well, this was followed by cemented and uncemented hips by Dr. Harish Vende and Dr. Anil Arora, and they really talked about the specifics, how to tackle the acetabulum, how to fix your implant in the acetabulum, how to keep the neck length, and various variables that are so important. This was again followed by Bill Thomas, and he rightly said that any defect in the acetabulum can be reconstructed, and that is so very important. And reconstructions can make an unperformable hip into a performable hip replacement so successfully. Well, even the case reports that we have been discussing, they also raised so many questions to be answered. Now, in a case of avascular necrosis, in which one hip is completely avascular and the other hip yet has not shown so much of changes, shall we attempt doing joint replacement in both at a very short interval, or we would like to delay? These are some of the issues which we have to ponder upon. And friends, the case which showed tuberculosis was also a very good case, and that also was deliberated in detail. So finally, it was a very good morning session which has extended till this time. I must congratulate Dr. A.S. Prasad and his full team. They, like every arthroplasty course, have made it so successful. Congratulations once again for this concluding 12th arthroplasty course, and we hope that the 13th, though it is said is unlucky, but I must say it is lucky for many, and definitely for Dr. Prasad and all the faculty members. So we are looking forward to meeting you all in the 13th arthroplasty course. Thank you. Thank you very much. Over to Dr. Prasad.
Thank you, Dr. Jha. And before you announce all the awards, I think you can announce the awards on this platform. Dr. Jha was the person who's looking after the award session. I would like to thank all my delegates who have attended. Maybe some people will be dropping now. So I would like to extend, whoever has watched our or attended our program, I would like to thank them. And I'll be hopeful that our program will help them in their career, getting better outcome for their patients, helping them in their future. And I would also like to thank all our faculties who helped many, especially the 3 doctors who came from abroad. Dr. Parvez Ahsan from Bangladesh, Dr. Tanveer Hassan Siddiqui from Bangladesh, and Dr. Ravindra Regmi, who showed a beautiful case from Kathmandu. So we are basically the Indian subcontinent or South Asia, you can say. So we all have similar cultures, similar constraints also. We all have gone through the same constraints which they discussed. So we can relate with each other very well. And I was very happy, and I invite them whenever we are going to have a physical meeting, hopefully next year. I want them to be here with us. So we'll make arrangements, sir. Please join us in the physical form also.
And thanks to Dr. Graichen.
Yeah. Thanks to Dr. Graichen, who has been, I think this was the 3rd time with us. And in fact, my non-doctor's assistant has learned from him how to close the knee also and also the hip. We did a revision hip together once, and once he demonstrated a knee also here. And he is a wonderful person, but very methodical. And his words, I remember once he said, he saw my difficult cases, he said, Dr. Prasad, God has been kind to you, but he may not be kind to you all the time. Just so take care. Don't try to stretch your indications. So that was a good statement, which I really follow after that. And our whole faculty, they have been lovely people. We all know lovely work they do. They all have very good principles to follow, and they all understand the constraints within which we all work. Professor Rajesh Malhotra is from All India Institute. He has got all the facilities, but still he realizes how we work. And that it was such a good thing to watch him. I have watched him surgery. I know he's so methodical. And whether it's a joint replacement or whether it is osteoporosis, there also he's so well versed. He will know everything, the nuances of treating. So he comes from the top institute, and he's absolutely worthy of staying there. He is really worthy of. He has got students scattered all over India. And my team is there always fighting for me, fighting with me, working with me. So I thank all my team members. They're all well known. I will not name everyone now. And thanks, Dr. Jha. You have been always with us. So thank you for being with us. So you may announce the awards now, or if you want to announce it later on, we can do that also.
I can announce now even.
Please do that.
Right. So in award functions, you will see the last is announced first, but I will not do that. I'm going to announce the first and the second later. So yesterday evening, we had a session of case reports, and Dr. Jayant Arora, he had made a presentation, just to remind you all, that he did perform a partial knee replacement with ACL reconstruction. So this has topped the list. Well, there were many controversies while we were discussing this, that a routine HTO could have been performed, but since he had his own experience for partial knee replacement, plus most importantly, in any branch of medicine, what becomes most important, that you talk to the patient. So that shared opinion was very important, and he had taken his decision by talking to the patient. And third, in his experience, he felt that these two surgeries combined together will give better results. Though it was really highlighted that a routine HTO could have done well. The second is Dr. Vishwas Sharma. Well, he presented 3 cases and decision making for a constraint TKA Well, all these three cases, the two cases could be shown completely. The third case could not be shown completely. And despite deficits, it was realized that this was a good, he had good two cases where he could fill up the graphs and could not, and did not require any constant TKA. So any comments, Dr. Prasad, on yesterday's, these two papers?
No, you're perfectly right, because yes, I do agree. The first one was combining two things, but what Dr. Arora showed that the result, number one, and that's why apart from the academic discussion, it was very clear that he was giving his patient in his prime of career, a very good quality of life. So yes, if it is informed consent, and because even STO will need something later on after 10 years. So it's same here. Yes, the revision surgery might be more difficult in a failed ACL and a uni, but that is a shade different, and we do not know what will happen after 15 years. The technology, the newer techniques will change. So yes, I absolutely agree with your decision now, sir. Absolutely agree. Yeah, Dr. Jha. I just hope his internet connection are not had a glitch or something. Okay. Yes, sir. Hello. From the poster session, sir, बता दीजिए नाम. Dr. Jha is on phone. He is announcing the name. अच्छा हो. Okay. Salin, good. He's working with me. He's my colleague also. so probably you don't know this. Okay. Dr. Aditya Narula gets the first prize in poster because he has shown the MCL repair with proper instrumentation and indication and why it should be known. This Dr. Jha says. Number two. Okay. Okay. Oh, I'll just announce it. The second poster award goes to Dr. Saket, and he has shown the infected implant can be retained with the use of bioabsorbable calcium, the granules, the antibiotic impregnated calcium beads. So he has shown the result, right, sir? Yeah, no, Ravindra Regmi was from Kathmandu. Okay. Okay. Mm-hmm. Mm-hmm. Mm. Okay. Okay, great. Ah. Okay. Yeah, that we have seen it. Yes, yeah, yeah, removing it. So, friends, we Dr. Mrinal Sharma gets the first prize in today's case discussion for such a well worked up case and restoring the biomechanics of the hip in a very bolted up case. And Dr. Ravindra Regmi from Kathmandu gets the second prize for a very well methodical worked up case of a tubercular infection in a old total hip. So these are the 6 people who get the awards in the 12th Kanpur orthoplasty course. And Dr. Jha says bye from here because suddenly his line is not there. So, sir, I'm conveying bye-bye from you.
Thank you from my bottom of my heart.
Mrinal, are you there or Mrinal must have left?